My name is Anubha Sood, and I lead the Total Care Program for Parkinson's disease here at the O'Donnell Brain Institute. Some of you may have seen me at the Zoom events that we organize, but we do all kinds of educational programming, offer resources, and you can access all of that through our Total Care webpage at the UT Southwestern website. A few things, you all may have the folders. There are feedback forms in there, and there's also now a Total Care Impact Survey. We really want you to fill out these surveys so that we can serve you better. You all have the agenda and the schedule as well, so it'll be a great program today. The bathrooms are sort of to the right when you go down, right after where our community partners are. Any questions, I'm here. Just raise a hand. I'll be there to answer. With that, I think I'm going to invite Dr. Sharma to give the welcome remarks. Dr. Sharma.
Good morning, everyone, and welcome to the Total Care Parkinson's Disease Symposium. We are truly glad to have all of you here, patients, families, caregivers, therapists, nurses, and physicians. April is Parkinson's Awareness Month, and every year we take this opportunity to raise awareness and provide education about Parkinson's disease. Parkinson's disease can impact many aspects of life and can be overwhelming at times. But we want to emphasize that you are not alone in this. Care works best when we work together as a team, and that is what is reflected in today's symposium's theme, Working Together for Better Outcomes, highlighting the fact that care comes through collaboration, sharing information, supporting each other, and learning as a community. Today, you will hear from our wonderful speakers from across the care team, and we hope you leave with practical tools, useful information, and a sense of connection and support. Thank you to the OBI team, Anubha, Sood, Janice King, Shannon, and a special thank you to our members of the Patients and Family Advisory Council team who have been extremely supportive and instrumental in shaping this program. Thank you to all the amazing community partners who have been doing tremendous work in supporting this mission. Thank you again, everyone, for being here. And with that, we'll be inviting our first speaker, Dr. Siegfried Hersey. He's a movement disorder neurologist and an assistant professor of neurology at UT Southwestern. Welcome.
Thank you. And it looks like there's a QR code. Okay, I'll leave it up for a little bit. And we'll come back to it, actually. All right, but I'm so happy to give this talk, and I'm actually giving this talk with Dr. Riki over there, and we've split it in half. And so we're talking about Parkinson's management and care, addressing evolving needs, and the learning objectives of this talk are part one, my part, the movement disorders clinician's perspective. One, describe the evolving and clinical and functional needs of people living with Parkinson's disease. Two, explain how Parkinson's progresses through stages and how symptoms change over time, and then identify common symptoms that impact daily care. And then part two, the neuropalliative perspective, will be introducing key principles of person-centered Parkinson's management and explaining the importance of individualized care, shared decision-making, and respecting patient preferences. So to start off, all y'all probably know, but what is Parkinson's? Parkinson's is the second most common neurodegenerative disorder. Our chair will have some comments on that, but That's the traditional statement, and over 1 million people are affected in the USA alone. And really, I like to stress that it is really a spectrum. It's unique. Everyone is different. Everyone feels their symptoms differently. But we talk about 3 main things that get affected, 3 systems. Movement, which is the primary thing that we talk about. Tremors and slowness and how you walk. But thinking and emotions are also changed, and automatic body functions like blood pressure regulation, temperature regulation, and other things are also affected. And these are the common areas that people with Parkinson's deal with. And Parkinson's is thought to be primarily due to the loss of dopaminergic neurons in the brain. And this loss is associated with changes with aggregation of alpha-synuclein, this protein. And there's some healthy debate as to whether that's the cause or that's just something that is seen with it. But let's go on to what changes in Parkinson's disease. And so dopamine, which is the thing that we focus on the most, but it's not the only thing that is affected from a neurotransmitter perspective. It is used by the body in various areas. We talk most about the brain, and there are several different kinds of pathways where dopamine is used, and we won't go into the details about it because that doesn't really matter as much in the clinical management. But in the brain, it's used for motor planning, initiation, and continuation of movement. In the brain, it's used for attention and concentration, motivation, and the common talk of dopamine being the happy neurotransmitter and getting you to keep doing things and getting reward. And there's also some involvement in hormonal regulation. And outside of the brain, there's use for promoting salt and fluid loss, so blood pressure regulation, intestinal activity, cardiac activity, and some effects in the adrenal glands, which are those fight or flight glands. So with that said, we can move on to how does Parkinson's progress? And so Parkinson's is a neurodegenerative disorder, and so that means it progresses over time. So things get a little bit harder and more systems are affected and more affected as time progresses. And that this progression is faster than what is expected in normal aging. And it progresses through stages. And these stages are more helpful for clinical trials and kind of to get a general sense of who someone is, but it's challenging because there are various things that can be happening. But I like to group things into early, middle, and late. And there are the Hoehn and Yahr scale and other scales that kind of try to quantify this more, and people ask about where I am on this scale. But I like the early, middle, and late, and I'll talk a little bit more about that. And so first, let's talk about the early stage. And so the honeymoon stage, and what I like to define it by is saying that it's well responding to medications. And so if we're going to talk about early, then we should talk about how does Parkinson's start. And how it starts is a matter of great debate, and we're not exactly sure, but we know it starts way before people start experiencing symptoms. And factors involved in the starting of this vary depending on the person. When we say it's a combination of genes and environment like most diseases, and that aging is a component too, and a primary component, because many people get it later in life. It can happen earlier, but it rarely happens in childhood, and in those cases it's mostly a genetic disorder. And then there's a lot of talk about, well, genetics. And we think that the minority of cases are just due to a gene, but then there's a fair number that are due to influences from genes where it increases the risk. But most cases we don't really find that, and we don't do genetic testing for. And then the last one that's been really talked about a lot recently is the environment and toxins, and what role are they playing. And that is an evolving field where we're trying to figure out how much that is a factor. Okay. So to recap, changes in the brain occur years before a clinician can diagnose Parkinson's, and the first symptoms can include various different things, and it depends what you're looking for, and it depends on the person. So one of the common ones that we talked about is acting out of dreams or REM sleep behavior disorder, where people, while they're sleeping, start to kick or talk or move around. Another one is loss of sense of smell, constipation, and these are non-motor symptoms that start early. And then other things that are noted are slight memory or cognitive difficulties from baseline and slight slowing of movement. But at this stage, prior to diagnosis at the beginning, it's not easy or possible to tell how much that changes from how you are as a person, because everyone varies, and so you can't really detect it very well at this stage. And so what does early stage Parkinson's disease look like? An early clinically manifest Parkinson's disease is defined by movement abnormalities that a clinician can see and a patient experiences. And individuals typically have tremor, slowness, stiffness, cramps, and pain. And treatments are typically very effective in the early stage. Dopamine supplementation results in great benefit. People feel like they return nearly back to normal. Dopamine supplementation results in long-lasting benefits. So no one's riding the roller coaster. You're not going up and down. You don't feel it really kick in or wear off. It just feels like things are generally better. And side effects are minimal. There are side effects at times, but usually they resolve as a person gets used to it, and the most common one in the early stage is nausea. But again, Parkinson's is not a monolith, and someone can be in the early stage and not align with all of the features here. And so just to talk about a few of those manifestations of Parkinson's disease, so one of them is tremor, and this is the one that is most obvious and was talked about the most. Tremor is shaking. And the more formal definition is rhythmic oscillation around an axis, and I have a little picture of what rhythmic oscillation looks like from a physics perspective. And the type of this shaking is, for Parkinson's disease, we talk most about the rest tremor that happens when it goes away when someone tries to do something. People commonly describe it as controllable, in that if they do something or clench their fist, that shaking hand stops shaking. But when you're distracted or doing something else, it returns. And this rest tremor usually bothers someone going to sleep, when someone is at rest or trying to rest, and when it's watching TV or when you're walking. But something that's left out and is a little confusing and complicated is that Parkinson's also frequently has an action tremor, and this one is not controllable, and this one most people complain more about when trying to do things, when holding cups, and when trying to write and move. And there's also a tremor that's commonly present, but this is not specific to Parkinson's disease, but it is seen in Parkinson's. And it interferes with these activities. And here you can see how we assess on the right the different kinds of tremors. So rest tremor, we ask people to sit. Postural tremors, there's this type of action tremor, is we ask someone to put your arms out. And then these kinetic tremors, we have various different tasks that we ask, like the spiral drawing or finger to nose, touch your nose, touch my finger, and then other things like holding bottles and whatnot. And then these are what the little spirals look like that that doctors often ask for from people who have tremors, and what Parkinson's disease looks like, which is micrographic, but this is not, again, uniform. Sometimes people with Parkinson's have a little bit of this. Is a essential tremor type movement as well, and then this is another more rare type of tremor that can exist. And then another key manifestation is slowness. And the doctor word for that is bradykinesia, which is decreased speed. And it actually encompasses two concepts of speed and hypokinesia, which is reduction in amplitude. So an initial movement will be big, and then it'll get a little smaller, and it'll get a little smaller, and a little smaller the more that movement is done. And also within this kind of realm, when we talk about it, there's pauses or hesitations where there's a slight stick, and then it'll go again, and freezes, where it's not a slight one, and it stays there for a little bit when you're doing these movements, and it hangs, and then it keeps going after that. And this is all within the bradykinesia slowness spectrum, and the symptoms are handwriting gets smaller, things take longer to do, walking is slower, and muscles may feel fatigued or weak. But when tested or when lifting a weight one time, strong. Okay, and it's actually the required feature of Parkinson's disease, and it is central to the disorder, and so everyone technically should have this feature. Okay, and then the last one, and we'll talk about it for the early stage, is rigidity. And this one is the most challenging one to talk about, really, because the definition is a clinician's definition of resistance to passive movement. So your clinician moves the arm around and feels that it doesn't move like it should, it's not loose. But the symptoms of rigidity are harder to nail down. And so people with Parkinson's experience stiffness and tightness, shoulder restriction of movement, reduction of arm swing, and things like that can be related. And then there's this tendency of body parts to stay static. Yep. But it's different from just pain or arthritis or shooting pains or spasms. Rigidity has this definition that really is this clinical one that's tight, but how it manifests in people kind of varies. Okay. And so importantly, or most importantly, what do people with early stage Parkinson's benefit from? And I think this list is just a list that I put together, and everyone can argue about what's more important, what's required, and what's recommended. But I put down that generally recommended in the early stage, it's good to have a neurologist, it's good to get evaluated by physical therapy, speech, and occupational therapy, like we were talking about. People benefit from having a team, and to set up an exercise regimen because we see that that slows down progression, and usually to try dopaminergic medications to see if there is a benefit. That doesn't mean that someone needs to stay on them, and it's not a 100% thing that, oh, you have to be on them, but we generally ask people to try, and the reason is that you don't really know what you could be missing out on in the early stages sometimes if you don't try the medication. And then integrating into a social support network is very useful too. And then the strong recommendations that I have are primary care doctor, you should have one of those, and development of a long-term plan and development and documentation of core values. And this is important because this is when people have the least change in other domains like cognition and mood. This is important to first set up at the beginning of what do I want my clinicians to help me with, and how do I want to deal with things as they move in the future. It doesn't have to stay that way, but it's good to start thinking about these things at the start. Okay, and so we'll move on to the middle stage. So adaptation and optimization are what I've said are the highlights of this stage. So things start becoming a little more difficult, but they can be managed with our medications well and with our advanced technologies. And so to me, what does middle stage Parkinson's disease look like? Well, it looks like some complications start to develop with getting dopamine supplementation. And there start to be a couple of side effects, and responses start to get a little bit shorter. And people at this stage learn what on and off means. At the beginning stage, people often don't know when I ask that question because it just feels generally good to be on dopamine, on dopaminergics, and it doesn't cause people to go up or go down. But in the middle stage, and really this is a motor perspective, this is a movement perspective of it, it is when this starts to go on and off, and people start to develop movement abnormalities like dyskinesia, which is motor intolerance to excess dopamine. So this is this wiggling movement that happens more when people are active and after medications are given, typically. And fluctuation, or motor intolerance to insufficient systemic dopamine. So people wear off. So get the benefit, feel it kick in 30 minutes later, but 4 hours, 2 hours, it varies from person to person. That benefit doesn't last as long as it used to, and that's a cardinal feature, I think, of middle stage. And then mobility and balance impairments, even when in an on state, start to manifest. So the medication doesn't fully get people back to where they were prior to Parkinson's. There start to be things that are not as responsive. And then the last thing that I talk about is that non-motor symptoms typically become more noticeable. And non-motor symptoms, there's really this big bag of different things that can happen, but again, those two domains are autonomic things like dizziness and lightheadedness and sensitivity to temperature, and then cognitive and psychiatric symptoms, they also become more notable. Not necessarily disabling, but it starts to be something that is talked about during visits. And again, not a monolith. Middle stage looks very different, and I think it's the hardest stage to really say because there are different aspects that can make something seem like the middle stage. Okay. And so in the middle stage, what we usually talk about most is this therapeutic window, and this graphic shows up all the time. And so it's nice to look on the y-axis, so up and down. There's blood levels of levodopa. And I think of that most actually as dopamine effect and not really what's in the blood. And so sensors in the blood don't work that well. And then on the x-axis, going from right to left, is starting in the early stage, going to the moderate and advanced, so time. And what we see for the early stage is that this up and down, this purple, actually indicates what dopamine is doing. And so we see you take your medications and then the dopamine rises in the blood or brain or the effect, and then it goes down and then it goes back up. But this going up and down that's dictated by your gut's absorption, it doesn't really reflect. It doesn't change anything because your brain actually absorbs it and stores it. And so if there's too much, it gets stored. If there's too little, at some point, it's still stored, and so it'll get released. And so there is no upping and downing, and this is the honeymoon period of early. In moderate or middle, motor fluctuations start happening, and what happens is you go up and you go up, but then you go two up, and what two up is usually dyskinesia and wiggly movements and extra movements, and I say to you that it's basically your brain allowing anything to get out, just kind of spontaneous background activity starts to escape because there's so much dopamine around promoting movement that it promotes it too much. And then it peaked up, and then you go down and down and down, and actually now the sponge capacity of the brain is not as high as it used to be, and you go too low, and you get stiff and tight, and the things that happened before someone was on dopamine start happening again, and this looks different for each person, but could be tremors and stiffness and tightness. It varies, and sometimes it's anxiety or other features, and then it goes up and down, and this is what happens, and we have medications that help make it go less up and make it stay around longer in the blood, and so we don't have it go up and down as much, and we deal with this issue. And then we'll go to the advanced state later, where it's even more fluctuation. But this is the hallmark that there's degeneration, and so that sponge capacity of the brain reduces over time, and this fluctuation develops. And so, again, another list, a list that came from me and could be argued extensively, but what do people with middle stage Parkinson's benefit from? And my general recommendations, in the middle stage, a movement disorder neurologist is really helpful. At the early stage, general neurologist, even primary care doctor can manage things because dopamine works really well. But in the middle stage, there's value to understanding how to use the more complicated and sophisticated medications that we have developed as a society. Additional involvement of social support to help with providing additional information, familiarity with common side effects of therapy is recommended. Logging symptoms can be very helpful because a lot of the things actually relate to when you take the medication or when you don't take the medication and are sometimes hard to describe without or ascertain their relationship without actually writing things down and keeping track of them. And now there are many apps and actually devices that can help with tracking these things. And then movement disorder doctors love having videos of what is abnormal, because what exactly tremor is to one person or another person, or what dyskinesia is, sometimes it's hard to describe. A picture is worth 1,000 words, and the video is worth 1,000 pictures. And then blood pressure cuff and regular checks, I think, is also helpful. And then the strong recommendation is at least having a neurologist, having been evaluated again by physical therapy, speech and occupational therapy. And in this stage, usually continuing relationships are useful. And then continuing your exercise, continuing to keep track of the long-term plan, and to continue to develop core values. And we'll move into the advanced stage. And so the advanced stage, I think, is focused most on compromises and collaboration. Treatments come with trade-offs, and stability becomes more important than perfection. And so what does late stage or advanced Parkinson's disease look like? The late stage, to me, is defined by reduced perceived response to dopamine and by prominent non-motor symptoms that are usually aggravated by dopamine. And so in this stage, individuals frequently develop things that don't seem to help with dopamine, like freezing, falls, cognitive changes, mood changes, visual hallucinations, and orthostatic hypotension or dizziness are these features that we see in people with advanced PD. And so now to talk about some of those manifestations. So dementia, or PDD, Parkinson's disease dementia, the definition is a progressive decline in cognitive function that interferes with the ability to manage activities of daily living, and due to Parkinson's. And the common features are, and there's a profile to the Parkinson's kind of change, or the alpha-synuclein kind of change, which is difficulties with executive function, which we think planning, managing things, doing math, difficulties with attention and concentration, difficulties with dual tasks, or doing complex things that require multiple things to be managed at the same time, driving and navigating, visual spatial, which means how do I look out in the environment and see how far something is away, and then plan how I will get around something or adjust to some movement in the environment, and fluctuation, which is this change that seems spontaneous and is hard to find why at one moment someone is worse and a little bit more confused, and another moment fine. And it's not really what's talked about in Alzheimer's, where there's ups and there's downs, and those ups and downs are usually related to stress or to some kind of trigger, like, oh, there's an appointment that day. In Parkinson's disease dementia and Lewy body dementia, it's spontaneous. And so for no good reason, this happens, and then the duration isn't a day. It could be just a few minutes, it could be hours, it could be days, and then or turn back to seemingly normal. And then later on, there's swallowing difficulties that happen. The next thing that I want to touch upon is Parkinson's disease psychosis, PDP. And this is a disabling change that affects reality perception, meaning that what we all think together as a group when we look at something or see something or get information is not what is perceived by someone in advanced Parkinson's disease, that they think differently from the information that is given. There can be delusions, which are focus beliefs of something despite objective information, and abnormal perceptual experiences, most typically visual hallucinations, where things appear out in the environment that don't have any actual stimuli to drive it. So people can see squirrels or animals or things when there's nothing there. And so the common features are visual hallucinations, like I said, paranoid delusions, like believing someone is cheating or people are stealing. Other types of hallucinations can happen, tactile, somatic, verbal, but they're rare and tactile. And then anxiety, depression, irritability, and other kinds of abnormalities, like feeling someone is in the room when there is no one, are features of that psychosis spectrum. And the next big one I'll talk about is freezing of gait, which is this change in movement where there are unintentional arrests. And so usually during the initiation or modification of movement, like a turn, someone with Parkinson's can get stuck. And this is actually sometimes challenging to describe. People will say, my leg, it feels like it's very heavy. I feel like I'm very weak at that point. I can't move it. And and it goes away after some amount of time, can be just a couple of seconds usually, or even less than that, and then movement can continue. But the primary thing is noting that it happens with initiation. And when you're just trying to get up, when you're trying to turn or trying to go through a doorway, and that this is associated with falls and balance changes and actually also cognitive changes. So the other notable thing for freezing of gait is that commonly it doesn't respond well to medications. The bothersome kind doesn't respond well to dopamine. And then we'll talk about labile blood pressures, which is another cardinal feature of advanced Parkinson's disease, which means that people will have their blood pressures go up and go down, and usually we describe this as lightheadedness that comes from standing, and then usually it's in the morning, and just getting up from bed because you've been laying down for a long time, there will be this sense of dizziness or lightheadedness, and then it'll resolve after a little bit. There's a formal definition that's also used, and that's why the blood pressure cuff is useful. But the reality is that people with Parkinson's disease can experience changes in blood pressure in different ways. And so, yes, people can experience feeling lightheaded, dizzy, or woozy, but it also can feel like vision is just narrowing, or there's some blurring, or there's this coat hanger, neck, shoulder tightness, or pain that happens with being up. And sometimes there's nothing at all, and people don't even really realize it, but they just move worse, they feel bad, and they fall or have near fainting. There's all kinds of different things that low blood pressures can manifest as. And then I think the last one that I'll talk about is falls and imbalance, and this is a big one. And unintentional loss of postural control is what a fall is, and the body collapses to the floor. And common features associated with falls are basically other advanced features of Parkinson's, and we try to figure out, well, why did the fall happen and how can we prevent future falls? And we look for the things that we can intervene on and that are associated. So sometimes it was something distracting out in the environment, or trying to talk to someone at the same time that resulted in a fall. And so, well, we need to focusing on your walking while you're doing it. Sometimes it's trying to carry heavy things and your center of mass goes to one side or the other, or because of Parkinson's, sometimes the spine bends to one side or the other, bends forward, and so that can lead to falls. And so someone say, oh, don't carry heavy things, don't move things off center of mass. Dyskinesia, wiggly movements that intrude, weird dystonic postures where the foot bends inward, which is seen in Parkinson's, can contribute. Freezing, dizziness, all these kinds of things can contribute to falls and imbalance. And so I want to just talk a little bit about what limits our ability to treat Parkinson's in the advanced state. And it looks like there's a little thing that was lost. Nope, I guess it just, interesting. Anyways, so on the left, there is this little confusing circle. And what I want to note is that there's several axes. So on one side, you can see that it says autonomic, motor, and cognitive. And you can see that there's a little red triangle there in the middle. And the further out it goes, the more severe the symptoms are. And so these are the domains that exist. And so the leftmost is a near asymptomatic individual where the red symptoms are minimal in all domains. And then the one next to it shows what severe symptoms in all domains would be, which is that it goes out very far to the edge. There's a lot of autonomic symptoms, there are a lot of motor symptoms, and there are a lot of cognitive symptoms. And so one could say, oh, this is early Parkinson's that's well treated, and this is advanced Parkinson's that's poorly treated or just very advanced. But what happens in advanced and to a degree in middle stage is that there's some symptoms, and people may come in for a visit and say, you know, I'm really bothered by my tremor, and that's really causing me a lot of disability, but you know, I'm not dizzy and I'm doing well cognitively. And we give Cinemet because that helps with tremors and motor features of Parkinson's, and then we see, you know, what, great, the 3 went down to a 1, and so the motor symptoms were improved. But what happened on these other axes? Oh, well, they actually went out and things got worse. And so this could be people, oh, I felt hazy. When I was trying to do things, I just felt like I was in a cognitive fuzz and it was harder to think straight. And this could be, oh, I started getting lightheaded and a little dizzy. And so, yes, my tremors improved, but now I'm having these other things and they're actually worse than the tremors were. And so, well, we have to adjust again and go down on the Cinemet or make some other change. And so this is really what limits our ability as movement disorders and neurologists in the advanced stage, is things come with a trade. And these graphs that I talked about in the middle stage become very important in the advanced stage, but they're even more complicated because here we were talking about motor symptoms in the advanced stage, so slowness or tremor or whatnot, and going up and down. In the advanced stage, there's more upping and downing, and there's more dyskinesia and off states. But what's true, the reality is that this isn't the only domain that exists and the only graph. There are 3 of these, lumping broadly, but there's an autonomic graph where blood pressure changes occur as you take Cinemet, and as it goes higher into the red zone, you get dizzy and lightheaded. Not so much that we know happening in the too low zone, but people can also actually feel like their blood pressures are off the opposite way. And more notably really is this cognitive domain where, you know, people, when they start Cinemet, either feel like, no, there's no real change to my thinking. I was always I didn't have any issues with that. It was all fine. Some people do feel like, whoop, I turned on and I actually can think better. I'm more clear and I think faster. But this has the same fluctuation. It's a little bit different, but over time, people, when they're in their off states, can struggle with doing math and feel like they're foggy. But when they're too high, they can actually experience the same thing. The dopamine has a toxic effect on cognition, not in a toxic sense that it's damaging the neurons, but in the sense that too much of it interferes with coordinating the processes. And so it has this unfortunate challenge. And the problem here is that these don't necessarily overlap. They're not the same. And so the same dose can work really great for motor symptoms and keep you in the green, but it might be too high for cognitive symptoms. And so that we can't get you to not have cognitive symptoms when you have good control of motor symptoms. And so that's usually the big issue in the later stages. And so what do people with late stage Parkinson's benefit from? Well, an established therapy team, continued exercise regimen. A psychologist, I think, becomes really helpful, and it probably should have been earlier as well. And then strongly recommended are a lot of things, but a caregiver and caregiver support, neurologist or movement disorders clinician, a palliative doctor, and again, you could argue earlier as well. And then the primary care team still needs to be involved, and a real documentation and understanding of what matters for their quality of life and what they want so that we can get the symptoms that they want best controlled and focused on. That's my spiel. And so I'll pass it off now.
Okay, so thank you, Dr. Hertzy. And whoever planned this event, I think that these 2 talks going together is great. I'm Jenny Rickey. I am not a movement disorder neurologist. That's my disclaimer. I actually do neuromuscular neurology, but I also do neuropalliative care, and that's where I interact with a lot of our patients with movement disorders. So I want to take kind of what we just talked about, the stages of Parkinson's disease, and pivot to kind of how do you as a person help your team develop a plan that is best for you. Because as Dr. Hertzy talked about, we can talk about Parkinson's disease as one diagnosis, but it affects everyone differently. So I first want to introduce this concept of person-centered care. You'll hear people say this, but what does it actually mean? As you just saw, each stage of Parkinson's disease is a unique journey. And I'm glad that Dr. Hertzy brought up that patients will ask us kind of what stage am I in? And what I tell patients when they ask that question is these stages are intended to group people. There are things that we have to group people for, such as research endeavors. But each person within that stage looks different. And so it's more important to talk about what a person is experiencing at that time. In addition to Parkinson's affecting people differently, everyone living with Parkinson's disease has different priorities and goals. So one patient I talked to might really want their motor symptoms controlled, versus another person may be much more focused on cognition, and that affects how they're going to choose to use medications. Support systems can vary vastly, whether that be the availability of private pay care or extra therapies, or just how much family and friends do we have locally who can help out. And that's going to affect our care plan. As I mentioned, we do try to group people for things like research, and focusing on person-centered care is an intentional effort to make sure we kind of undo that way of thinking when we're caring for an individual patient. So that's what it is. What does it look like? And so, as I've said multiple times already, the word intentional. We have to be intentional about doing this and making efforts to understand a patient's individual situation, their values, their goals, their support system. When we're talking to patients, we're going to look at motor and non-motor symptoms. We're going to do a complete medical history. Maybe they have another medical issue that affects this care plan. We also want to find out, what is a patient's social support system? What are their spiritual needs and priorities? Person-centered care needs to require a discussion about prognosis. One of the things that actually led me to want to do palliative care was Parkinson's patients. And I found that we would sometimes encounter Parkinson's patients in the advanced stages, and they had never really been told about what that could look like or given the opportunity to plan ahead. Person-centered care needs to integrate a neurologist. A movement disorder neurologist is key in later stages, as we talked about, a primary care physician, and then there's also multiple other specialists involved. So what does this look like in the real world? Unfortunately, in our healthcare system, what we tend to encounter is there's a medical team over here, maybe therapists, a PCP, there's a neurologist over here, and then the support system and the patient are kind of seen for a visit, maybe a little bit of information is gathered, but there's not a really good way to interact between these groups, right? And everyone's kind of living in a silo is a term that sometimes we'll use. And it can feel like there's a fence in between the patient and the support system and the medical team, like you're not part of that care planning. What we want it to look like is we want the patient right in the middle. We want the neurologist, the medical team, the support system, we want all of them interacting with each other, and we want the patient to have access to those communications and the ability to share their opinions and their beliefs about their care. So in order to deliver kind of this model, as I've said a few times already, we have to know what's important to the individual patient. And that brings up another concept called value-based care. So in health systems, sometimes you'll hear this be a term dealing with money involved in care, but what we want to talk about is personal values. So all care decisions that are made for a patient ideally should take into consideration and actually revolve around what's most important to that specific patient at that specific time. This is going to change over time. As we know, Parkinson's is a chronic diagnosis. Needs evolve, and as those needs evolve, people's beliefs about certain interventions might change as well. We have to recognize as healthcare providers, and I know we have some providers here today too, that we're biased. My opinion about what's important for a patient may not be what's actually important to that patient, and so it's important that we're intentional about recognizing that. My recommendation for healthcare teams is having frequent discussion about a patient and family's personal values. And I encourage patients to think about these things and bring them up to their care team. So since we have some providers, I know therapists, nursing, et cetera, here today, I want to just briefly touch about some of these things from the provider side. I think it also gives you guys insight into what should be coming up in your visits. So essentially, when I tell providers how to explore these things, I think it's important just to ask, given what we're dealing with, what's most important to you right now? Because we're never going to know if we don't ask. Also asking, what is the most bothersome symptom? I will often see patients in my clinics who have a lot of dyskinesias related to medication, which I think, oh, that's something we need to treat or to fix, but the patient will tell me, no, I would prefer to have a dyskinesia than not be able to move or be in the off state. Another thing is asking people specifically, how much does this side effect or this issue affect you? We see side effects as bad, and they are, but sometimes patients consider them worth it to get the good benefit of the medication. So these are things that you want your providers to be exploring with you. Now, I just talked about what ideal person-centered care looks like, and it sounds great, but how do we actually execute this? How do we build a care team? I'm really glad Dr. Hertzi talked about this, but there's a lot of people available on the care team. So we want a neurologist, we want primary care. I'm biased, but I think palliative care is important at all stages of a progressive neurologic illness. Psychiatry can be very helpful. Sometimes we have access issues and not enough physicians, and we really lean heavily on our advanced care providers, nurse practitioners, and physician assistants, and we have some great ones here. Also, most of our patients have other specialists involved: dermatology, cardiology, pulmonology, endocrinology, because Parkinson's is a disease that typically happens later in life, and so we might have multiple other chronic health issues. You need a dentist, and is that going to change as you progress through Parkinson's disease? Physical therapy, occupational therapy, speech therapy, family therapy, a social worker. You might need some private caregivers to help out at home. Support groups, maybe we're taking advantage of a day program. So why can't we just have all these things, right? It sounds great, all that support. And I think there's four main reasons. One is time. If you spend all of your time seeing all those people throughout a chronic illness, you're not going to be doing anything else. The other is money. These things cost money, and people have limited financial resources. Parkinson's is a disease where fatigue can be quite prominent, and so we want to budget our energy to do things that we want to do, and maybe those things aren't it right now. And then also, these things are often spread across multiple healthcare systems, and it falls on the patient to coordinate a lot of it, and that can be very hard to do. So how do you decide who should be on this team? It's a balance, and it's a very complicated balance that's going to change over time. The thing that I counsel patients on first and foremost is it is okay to say no. You are going to have doctors telling you, look at these 25 resources that you can benefit from, and you're honestly the only one that knows if they actually provide a benefit. If we go to physical therapy and we didn't think it was helpful, your doctor needs to know that, and you need to stop going until it's something that's actually beneficial for you. This is going to change over time, and so these rocks are going to change in size. We're going to have different ones that we choose to put on this balance, and it's important to continue to discuss that with your healthcare team. So it's very easy for me when I see a patient to say, I'm going to send you some home health orders for therapy, but it's okay to ask, what's our goal with this? How is it actually going to benefit me? Is this the best use of my time right now? You need to recognize that you're an expert. When I see patients in the clinic, I'm seeing them for 30 minutes or an hour every few months. That's a very, very brief look into your life. And so do not be afraid to speak up and share your expertise about what you're going through. So again, for providers, how can we help patients figure out how to prioritize their care? And these are things that if your doctor's not asking, bring them up. Don't be afraid to. So providers should be specifically asking about values like we talked about before. We should be providing a clear explanation of what each resource should look like. So if I'm ordering physical therapy, it's important to me that I tell the patient, this is my goal for the therapy. If this isn't happening, circle back with me because we need to revisit how we're going to reach that goal. When providers are asked, and this is something I counsel our neurologists about, we're often trained to kind of focus on what we call autonomy in medicine and let patients make decisions for themselves, which is very good. But sometimes patients actually want us to make a recommendation and we don't. And so it's important that if patients ask for a recommendation and we have the ability to make one, that we actually tell them what we think is best in that situation. It's also good for us as providers to be aware of community resources. A lot of the needs of patients with chronic neurologic issues such as Parkinson's are not met by our traditional healthcare system, right? And so we work and we lean on our community care partners. What we ask of patients is if you have a really good experience with someone, tell your doctor, because there are other patients who might benefit from that. And that's one of the best ways that we gather this information. Okay, We're doing great on time, so I'm not going to get in trouble, which is good. Awesome. So I just talked a lot about these are the things we should be doing. Well, how do you effectively communicate these things to your care team? When you are going to a doctor's visits, I have some recommendations as to how to make it most effective. Always prepare. So it is okay, and I actually love when patients show up with a list. We may not get through that whole list. I may have some priorities that I need to discuss, but I need to know what the patient's priorities are. Don't make this list alone. Work with your family members. If you're working with therapists, if you have private caregivers helping, ask them to say, is there anything else you've noticed that I need to bring up to my doctor? Prioritize this list. As I said, our healthcare system, it has us working on some tight schedules, and y'all have probably noticed that when you go to the doctor. And so we want to make sure that we know what's most important in case we have to table some of those things to another visit to have adequate time to discuss them. You may feel sometimes like your doctor is not hearing what you're saying. That is reality. Doctors are humans, and we're not always the best communicators. And so I advise patients to prepare for that situation. Practice a couple phrases that if you feel like your doctor is talking about all the things that don't matter to you right now, how am I going to say, hey, we need to talk about this? I think one that is very polite but also direct is, this is helpful, but I really feel like it's more important for me to address this, and insert your priority. But practice that, so if you're ever in that situation, you have that to lean on. Summarizing a plan is really important. I am a doctor, and when I go to the doctor, if they say more than 2 or 3 things, I'm gonna forget half of those. And so be intentional at the end of your visit to say, okay, what are our action items, just like any other meeting. Take your own notes, that's okay. View your patient instructions. Most physicians' offices now, you'll be able to see the doctor's note on there as well as your instructions. Look at that, read that. And don't hesitate to follow up if something's not clear. Again, doctors are humans. Sometimes we make typos. Sometimes we end a sentence where it's not supposed to end. If something doesn't make sense, reach out. So another thing that patients ask me sometimes or say to me is, I don't even know what to ask. Like, I don't know what questions I should be asking. So I want to talk a little bit about questions that'll be high yield for you in a doctor's visits. So when we're talking about things like pharmaceutical treatments or medications, it's important that you understand these things. So if it's not explicitly said to you, you should ask. So how do I know if it's working? What is the benefit that we're looking for? What side effects should I look for? Are there other options for this symptom? And that's an important question because that helps you know, do I just need to see if I tolerate the side effects? Or if there's a side effect, should we be switching to something different? Am I eligible for clinical trials? If that's something that you're interested in, ask. When we're talking about other therapies, as I talked about before, we can order all the things in the world, but how do we know if this is the right thing for us right now? Ask your doctor, what therapies might I benefit from right now? What symptom is this going to help me with? And what will it look like? Now, there's a difference between home health therapies and outpatient therapies, and there are pros and cons to each. And so that decision needs to be made with your physician based on your current care needs. So ask them, if they order PT, say, do you think there's a benefit from me going to outpatient, or is the benefit more to have someone come into my home? I often will have patients say, hey, I saw this treatment online, and they'll be kind of fearful to talk to their doctor because it's not what the doctor recommended, but we want to hear about that. If you've read about something and you want to know if it works for you, ask your care team. So people with Parkinson's have a lot of care needs. As we saw in the first part of this presentation, medications can work really well at the beginning stages with this diagnosis. But then we run into an issue where we have more trouble with our day-to-day activities. And so how are we going to continue to live life to its fullest knowing this? Ask your team, do I have access to a social worker or a nurse navigator? These are people who are going to have a lot more information about community resources than your physicians will. Ask, given what you're seeing, should we be having more care at home? Does someone need to be around all the time? Is it okay to have breaks where my loved one or myself that we're independent in the home? And then do you recommend any specific support groups or community resources? This is something that may not come up in a visit unless you ask about it. The other things that we want to think about is planning for the future. It is never too early to have conversations about what our priorities might be if we were seriously ill or hospitalized. And that's not just true for patients with Parkinson's, that's true for all people, right? So with the natural kind of progression of this diagnosis, it's important for you to ask your doctor, what are you seeing? When do you think I might need more care? What might that care look like? If you have a specific goal of something you really want to do, it's okay to say, is it realistic to think that I could do this? And what do we need to do to make that happen? Your medical team is happy to help you in planning for these things. I always encourage patients to ask not just their neurologist, but all of their care teams for whatever chronic diagnoses they have. Do you expect any decisions to come up in the future that we should go ahead and talk about or think about? So we're nearing the end, and y'all are an excellent audience. We appreciate, I know it's a long talk, but other questions that I often get from patients that I kind of wanted to cover is, what if my doctors aren't talking to each other, right? Ideally, in our healthcare system, we would love for your PCP, your neurologist, your cardiologist to all be on the same page and to have communicated before you see them. And that frequently doesn't happen. And so what I advise patients is, if you have doctors who are actively managing your care, if they're not conversing, bring the latest progress note to your visit in case your doctor doesn't have the note from the cardiologist. Having those things physically with you is a way to kind of enable that communication. And unfortunately, sometimes picking up a little bit of that burden is the best way that you're going to get this interdisciplinary care. What if I don't like what my doctor is saying is something that patients will ask me. And the first thing I want to say is that's okay. Anyone on your care team, the priority is you. And so if a patient doesn't like what I've said, wants another opinion, that's great. We encourage that. And so don't be afraid to share these concerns. Your team can always help you seek other opinions or other input. What if I don't understand, and I saw this morning, I have a typo, what my doctor means, not why. So what if they're talking and talking and talking and it's all going over my head? They're not communicating well. Speak up. Tell them, hey, I need you to rephrase this. I don't quite understand what you're saying. We as providers would much rather a patient say, whoa, what's going on here, than have a patient leave the room and have no idea what just happened, right? So don't be afraid to speak up in those situations. What if I hate using the app? So as a healthcare system, and the app, I mean MyChart, we as a healthcare system have moved to a lot of these electronic means. And I found that a lot of patients have really enjoyed these, but I joke that it's like politics. Telehealth and MyChart are like politics. It's very polarized right now. People are either all or none. And so that's okay too. You need to share that with your care team though, because our main way of communicating is frequently by sending you a message. If you're never going to read that message, please tell us so that we can advise our nurses to communicate with you via phone. We do still have phones, and some of us know how to use them. Now, for providers who are here, how do I communicate with patients? And for patients and caregivers, what should my providers be doing? So it's important for us all to recognize that even the best communicators, patients aren't going to remember everything. There's a lot covered in a short visit, and we only can retain so much. And so I encourage providers to have very detailed patient instructions. If we covered a lot, I'm going to print that out and go over it with a patient and hand it to them. So everything is right there. In our notes, because we talked about how you can view your doctor's notes now frequently, for better or for worse, that we have clear plans that patients can understand, that other physicians can understand as well. When we're making medication changes, and this is something that patients can initiate as well, we encourage people to do what's called a teach-back method. So I'm going to say, we're going to change your Cinemet to this time, this time, this time. I want to make sure you understand it. Can you tell me what we're going to do with your Cinemet? And so you as a patient, you can say, hey, I want to make sure I understand you. This is what we're going to do. And that's much more effective in having people retain or remember what our change to plan is. It's important for providers to remember that goals and priorities change over time. So someone may tell me early when living with Parkinson's that they would never want XYZ. And then they get to a later stage of the diagnosis and they say, actually, I'm okay with that. And there's actually scientific data behind this. When we talk about what interventions we might be okay with or not okay with, it's typically based on what we consider to be an okay quality of life, right? And that's a term that we kind of throw around. There's data that shows that we as providers underestimate people's quality of life. So the example I used before where I see a patient with a dyskinesia, I might assume that must be really bothersome and affecting their quality of life. And the patient will say, no, this doesn't bother me at all. I, went out to dinner last night, had a great time, saw my son. I'm a great day. Everything's fine. The other thing that we know is that patients actually underestimate what their quality of life will be in the future. And so if we ask a patient with early Parkinson's, what do you think is an acceptable quality of life? They may say, this would be terrible. But then if they're experiencing that symptom years later, they may say, I'm actually fine. My quality of life is good. And so that's why it's important to revisit these things, because as patients and as providers, we make wrong assumptions about what things might look like or be experienced like in the future. It's important that we utilize other members of the multidisciplinary team to reinforce key points, right? And so if there is something that is so important to me in that visit, I should be communicating it to the physical therapist or the psychiatrist or whoever else is going to be involved in managing that so that it can be reinforced at that next visit. As I've said many times, it's really easy for us to order physical therapy, all these things, right? Sometimes we do a bad job of putting on the order what we actually want. And if we do that, the physical therapist doesn't know what to do, right? And so it's important for us to be clear when we're referring to other specialties what the goal of that is. I have on here for providers, don't expect patients to communicate the reason because that's really unfair to patients. Unfortunately, sometimes as a patient or a caregiver, though, you're going to end up in that situation. And so that's why it's important to discuss with your providers, what is our goal here? So that if that message gets lost, you can help in communicating that. The last thing I want to just briefly touch on is this concept of advanced care planning. This is another term that's kind of thrown around with it's a broad topic. And so when I talk to patients, I like to kind of clarify what's the most important part of that. So when I talk about advanced care planning, I present it to people, and I think that it is a way to protect people in those values that we should be learning about as providers. Medicine has evolved in a huge way over the last 50 years, even over the last decade, right? And so there's a lot of things doctors can do. We can do a lot. And so there's this concept of doing 2 patients versus doing 4 patients, right? If you've ever had a loved one hospitalized, you'll see that physicians are very much on a kind of goal-oriented mindset of my goal is to treat the organs, make the systems better, right? And so it's important that we recognize as physicians that that's doing 2. We're trying to do all the things that we know how to do. And what we should really be focusing on is this intervention serving the goal that the patient and the family have? Are we doing it for them? So in order to know this, though, doctors have to know the values of the patient and family. As we talked about, we have biases and we will assume things that aren't true. And so in order to make good decisions, we have to be exploring values, and your physician should be exploring these things with you. Now, how do you protect yourself and try to make sure that who you are as a person is honored in any sort of serious illness? The number one thing that everyone should have is what's called a surrogate decision maker. What this means is if I ever can't talk to an individual about their healthcare, who do they want to be their voice? Who do they want me talking to? In the state of Texas, if you don't have a medical power of attorney, physicians know that the person they should go to is a legal spouse. If that person is unavailable, it is the majority of adult children. I have a lot of people who say, that's exactly what I want. And I say, okay, that document's not as important. I have other people who say, you are never gonna get my kids to agree, or Aunt Brenda's gonna fly in from somewhere and mess everything up. And that's when I say, okay, we need to do this now. This document needs to be done. From that point, the most important thing for you is that that surrogate decision maker knows you, knows what's important to you, knows what your thoughts are about your healthcare. If you want to involve your medical team in those conversations, that's great. That's why we're here. And we can also help to talk about what different things may look like. There's other documents. There's an advanced directive to physicians. I tell patients that document's very black and white. It says, in this situation, I want everything or nothing. And what reality is more gray. And so that's why I say prioritize the medical power of attorney. Lastly, you should educate yourself with your care team about what code status is. That's something you should discuss with your doctors to find out if you have any specific preferences regarding that in case of a serious illness. Okay, so we just talked a lot. What are kind of the main take-home points? Parkinson's disease has well-defined stages, but everyone's journey is unique. Non-motor symptoms might be equally as important or bothersome as motor symptoms, and sometimes may not be the things that are most evident to your doctor. So make sure you're speaking up about what you experience. And then you, as patients and caregivers, you play almost the most important role and really should be at the center of designing a care plan that's right for you. Lastly, and I hope that I make Anuba proud with this, resources. So we're going to talk about a lot today, but this is, if you Google UT Southwestern Total Care, this is what pops up first. And there's tons of links to resources on there, as well as some videos from prior events and things like that. So as we talked about, when you go into a doctor's office, you can't absorb all the information. I assume that's going to be true today too. And so here's kind of somewhere you can follow up. And then I'll put the QR back on while we do questions.
Okay, we have mics here. So if people have questions, we'll pass the mics around.
Hi, I was just wondering why no one's talked about DBS or other surgical kind of treatments. And as a person with Parkinson's, my goal is to stay in as low a stage as possible. And for me, the DBS moved me back from stage 2 to stage 1 or 1 1/4 or something like that.
I'm not sure if we have anything about neuromodulation on today's agenda. So things like DBS, but those are huge in the treatment of Parkinson's and are very beneficial for some patients. I do think we've had talks previously, though, that may be available on that Total Care website as well. And so if you have a specific interest in kind of learning more about that, that would be where I would direct you for sure.
I'll say there's a lot to talk about, and we didn't really want to focus on treatment because there are a lot of things, but yes, it's a very valuable tool, and I echo those statements that there are whole conferences and meetings about DBS, and those are useful to go to.
Are there other non-traditional treatments, or there, I'm sure there are, but can you comment on those, or are there places to get, to find information about those non-traditional treatments to try to get whether they're valid or not from users, people who've tried them, or I see folks that are promoting things, and I don't know whether they're legitimate or not. Is there a means of following up on some of those non-traditional treatments to see to test their validity?
I'll take it. because I'm the tech-interested individual, and so there's a lot out there, and I think it's a good thing to discuss it with your clinician, because the main thing is there are risks to all interventions and there are potential benefits. And so it's a nuanced discussion when the clinical evidence is limited. So then we have to say, okay, well, what are your risks and what are your potential benefits and what do we estimate the likelihood that it will do something? And one of the new phrases that I like is for some of these devices like stimulators or electrical modulators, like the beach band that people have heard of, I say, okay, if it's an Amazon impulse buy, we're like, oh, there's no cost, and like, I don't mind if it doesn't work out, and it's a reasonably safe thing, then yeah, go for it. But if it's not that, and you're kind of thinking about it a lot, oh, should I do this, should I do this? Then really talk with your doctor more about it. And then that's from a tech perspective for like diet interventions and other kinds of, lots of different kinds of pharmaceutical things or nutraceuticals that can be tried. I'd have the same kind of statement of talk with your provider and talk with other people as well, the community, and look at the data. What data is there? What have they actually published? A lot of groups talk about things, but then they don't actually want to do the research to show that it works. And so that's my spiel.
I loved that spiel because it was an example of value-based care. But yeah, so it is risk-benefit. And so risks are also different for every person, not just medically, but things like financially, right? Some people have a few $1,000s that they can throw around on nothingness, even if there's a very low chance that it works. But sometimes we need to be very mindful about conserving things like financial resources for future care too. And so it absolutely is a discussion with your physician, and Dr. Hertzy's answer made me very, very happy. We're gonna repeat the question.
Does that change the treatment? And two, is that Parkinson's person eligible for the treatments, the infusions for the Alzheimer's drug?
So to repeat the question, it's there are some newer treatments for Alzheimer's dementia that are infusion-based therapies, and there are some blood tests that will show biomarkers that show that people might have that condition, and there might be overlap between Parkinson's and that Alzheimer's pathology. So the question, and make sure I'm getting it right, is would a Parkinson's patient with those blood markers be a candidate for those dementia treatments? I'm gonna let you answer.
So it's actually a very interesting area, obviously, and it's not yet. So there's clinical trial, one that should be happening, I think, that will be evaluating that. But the current statement right now is that with co-pathology, or with primary pathology being Parkinson's or alpha-synuclein, there is not insufficient evidence to use those treatments. And so we're going there, but those treatments are risky, and there are higher risks if you're actually just treating something that's on the side. And we don't really know yet how these things interplay. We had this thought of simple systems, of this is Alzheimer's, and this is Parkinson's, and this is dementia with Lewy bodies, and these are different things, and we like grouping things. But now we know that it's all mixed, and it's all complicated, and how does this really change things? The first question was using our serum markers. If you have co-pathology present, how does that change where you're going or what's happening? We don't really know yet, and so we're moving there, and we're learning all together, and so hopefully we will know more in a couple of years and not too long. Sure.
Are you finding that a lot of the Parkinson's dementia patients actually have Alzheimer's? Is that a high percentage, or is it just a rare occurrence?
So I think as a field, we need to do more testing, and there's a research context to do it in. But right now, as a clinician, it doesn't change exactly what I'm going to do for you. And so we aren't mandated to get that test. But for people who want it, we can obtain it with all the caveats of we don't really know exactly what to do with it. The reality is that there are people with full DLB, dementia with Lewy bodies, without any Alzheimer's co-pathology present as far as we can see. And in pathology, there's always a little bit of this and a little bit of that. But there are people who are probably true. Everything is Parkinson's related. Everything is alpha-synuclein. There are probably more, this kind of mix of things going on. And then there are those who actually have Alzheimer's or tau, but then really look like they had Parkinson's. And so it's complicated. The reality is it's very complicated. But you're right that I think the field is moving to the idea that, there's a mix that's happening when people go on to develop Parkinson's disease dementia, when there's more going on, that it's a little different beast.
Yeah. It's also important to know that these newer medications that are available, they were studied in very specific groups of people, and we're just now looking at expanding them to these other groups. And so we're not in a situation where we have good data. When patients have the priority of, I want any potential treatment I can get my hands on, even if it comes with significant risk, that's a time where sometimes clinical trials are your best way to access those things. But again, you're going to have to meet strict criteria for that. But don't be afraid to ask your doctors about, is there a trial where we could access this?
I have two questions. One is, what is the difference between Parkinsonism and Parkinson's disease? It's very confusing to the patient as well as a caregiver. And secondly, the Parkinson's Association just sent out this past week information that stem cell therapies have shown considerable benefit in Parkinson's disease, although they're not ready to be released. And could you comment on that?
Yeah. So first question, what is the difference between Parkinson's disease and Parkinsonism? In Parkinsonism, you can think of it in two ways. One is as clinical features that we see, and the other one is as a more broad category encompassing several different diagnoses, and I think that's the more usable one. Parkinson's disease, the majority of Parkinsonism is Parkinson's disease, at least the classical conception of it. But there's also other entities that are related, like multiple systems atrophy, dementia with Lewy bodies, and there pure autonomic failure. But anyways, there are other things that can exist within these spectrums, and PSP is also a Parkinsonism. So Parkinsonism sometimes is used when we don't really know what diagnosis to give you, and we're saying you have these features on exam, but we're going to figure this out, and then usually that diagnosis converts later into an established diagnosis of either Parkinson's or one of the other mimic disorders. So, or sometimes something else. And so that's usually the label, why that exists.
And then the second question was about stem cells. I'm going to give my two cents, and then hopefully you know more about the recent stuff. Stem cells are sexy. People love talking about stem cells. And so, this discussion of stem cells and Parkinson's has been going on for over a decade, which I only know because I did a meta-analysis in med school. And then I didn't do movement disorders, sorry guys. But as far as things being fun to talk about, it's definitely up there. Are you aware of any recent advances where we're rolling these out clinically?
I don't think that I'm not aware of it being rolled out clinically. And I want to give my spiel on this as well, and then we can hear other spiels. But the fundamental hope is that we're looking for something that's neuroregenerative, right? That we are hoping that these stem cells are going to go in and they're going to restore function and they're going to roll back the clock, or at least they're going to soak up some of the bad stuff that's going there and let the other cells hang on for longer. But what's really being studied at this point rigorously is not regeneration, but dopamine production. And so we are placing little factories directly into the brain to produce dopamine. And we don't want them actually to go out and start regenerating everywhere, because unfortunately, that's a tumor-like behavior. If it starts spreading around in your brain, that's a little concerning. And we actually look in the trials to make sure that they are not spreading, they are staying where they are supposed to be. And so I think that there's a little bit of a disconnect, and sometimes there's a lot of discussion and hope, and I think hope is very good, and we're moving always towards that neuroregenerative, but I think that right now, most of it, we're focused on just trying to find a new way of giving you dopamine, and that it's not fundamentally different, and that people should not be trying to fly somewhere necessarily for this to get it outside of a clinical trial. And always think about what the options are and the comparators, like, oh, should I do stem cells versus getting DBS? Like, what do we know helps, and what are we looking to see if it helps? And so there, again, another discussion with your doctor is useful about these things.
Hi, my family is here with me, and I've been doing a lot of reading on my own about some different treatment options, and I just wanted to hear it from the horse's mouth, so to speak. There's a study at A&M University by a Dr. Ashok Shetty about a nasal spray that can help inflammation problems regarding dementia. Does that have any impact in a Parkinson's patient?
I'm not familiar with the study. So there are a lot of things that potentially could help. Like and I'm very happy that we have all of this research that's going on. But the honest thing is we have to look at it, and a lot of things are preliminary. They're like, oh, we tried it on 10 people or 20 mice or something like that. And so I'm not aware of that study.
Yeah, what I would say to pretty much any question about an ongoing clinical study is, first of all, you can talk to your care team and they can show you how to navigate a website called clinicaltrials.gov. That lists all of the clinical trials available. But the people who are not doing the clinical trial are unlikely to know the details of the clinical trial. And so that makes it hard for us to speak to it because we don't want to misspeak, right? But on that clinical trials website, there's always an email address of a contact person who can tell you more about what they're doing and if you would be a candidate.
I guess that's like that brings me to like the crux of the issue for me is that I feel like the people that are on my family's team have a lot of ideas, and they've pushed a lot of medicine on us, but we're not really sure how it all works together, and like how do I get them to talk to each other?
Yeah, and so that goes back to figuring out what's most important to you that they're communicating about and telling them. We as healthcare providers are often not the best communicators with each other. Our system is not built to make it easy for us to talk to each other, to be honest. It is almost just as hard for me to get a hold of your cardiologist as it is for you to get a hold of your cardiologist. And so I think if you can clarify with your family, what is the concern? What are they not talking about? And then sometimes you have to take an active role in promoting that communication. So if it's, I want this doctor to know what this doctor is saying, bring the progress note and say, this is what he said. What does that mean in the case of this? It's an unfortunate part of our healthcare system that we are in silos. People are actively working to improve that. The other thing is sometimes if your specialists aren't talking, talk to your primary care doctor and see if they can be a point person to help you kind of collaborate this information.
Yeah. And then just going back to the research component, sometimes you can just bring the paper, the study or whatnot in, and you say, I've read about this, or I heard about this, and you show your doctor that thing, and then you can have that discussion at that time with information instead of being the cop-out answer that the doctor will give sometimes. I don't know about that one, sounds interesting. So, yeah.
Maybe one more question and then we have time.
Could you please address high-intensity ultrasound treatment?
Yeah, and so I think Dr. Sharma is going to bring up some more things as our head of neuromodulation. But I I think there's a lot of promise, and I'm actually very excited about how things are going to go. There's a lot to be learned about the comparison of deep brain stimulation versus ultrasound. And so, but there are cases where we may say, you know, this is a better option because it doesn't have certain risks. And again, this is all about risks and benefits, and what do we know about it? And what do we learn from our clinical trials and our general expertise? And then how do we talk to patients about what we're seeking from this intervention, and can we match that? And so for certain individuals, I'll go into a little spiel. Focused ultrasound sometimes creates more issues with gait, like balance impairments, but it is really good for tremor control. And so we'll see, oh, if tremor's the main thing and your balance is good, perhaps this is a good way to go if there are other kind of medical issues. So there's a very nuanced discussion that happens. And again, the field is evolving. And so I think that it's good that we now have this option and that it is going to be used. I don't think it's going to replace deep brain stimulation, but we'll just see how it plays out. And I think I'm very excited actually about how it's going to help for people who are considered advanced. And so our DBS concern has been cognitive concerns when we place the lead, when we give you anesthesia, but we don't have to do any of those things when we do focused ultrasound. And so we may be opening up options for people in a different place.
And I want to echo that should be a conversation with you, with your doctor, because it's going to look different for everyone, and it depends on what your goals are too. So as Dr. Hertzie says, we can cause more issue with gait, so we want to make sure that a patient isn't looking to improve their gait with that intervention. And so again, it's important to have the conversation of what is the potential benefit for me, and what are the potential risks for me, because it's going to be different for everyone. We're getting cut off, guys.
So I just want to add, at this point, we are also exploring new targets for Parkinson's. And we don't know, like we haven't compared head to head, but the newer targets, the hope is they may not be causing those sort of issues which have been approved so far. So again, there will be a trial at our center, and also last year, a new target was approved by FDA also, but we have very limited data on the outcomes. So definitely it's a promising therapy, and definitely is another option for patients, which you all should discuss with your physician.
Okay, so we are out of time. Thank you again, Dr. Hersey and Dr. Ricky. This was such an excellent session. I do want to mention that the Total Care Program did this amazing Ask Your Doctor series. So you can go on our webpage. All of these questions about DBS and HIFU, they were answered by our specialists. So you can go watch the videos. They're all available on the Total Care webpage. Thank you so much. Okay, so as we get ready for our next session, and I'm going to call our next session panelist speakers here forward. And as they settle here, I want to make a few announcements for our continuing education credit folks here. At the end of the day, we will give you the QR code, the link to sort of sign out so that you can get your credit. So that's for our PT, OT, speech therapists, and our nurses here. And then I also wanted to mention that for our final session, which will be right after lunch, we are collecting your thoughts on some of the questions that our panelists are going to answer here. So we have people here passing out some paper, some paper that you can write on, and there's some prompts. So we would want to collect those at lunchtime and have our panelists here sort of take those questions on from our audience. That's it. So welcome to our second session. Just move this. It's pretty easy. Should we give everyone a break?
We've got the snacks out,
Now, is it now?
10:30 to 10:45.
This was now? Okay, yeah, it was, yeah. I mentioned.
I think we're gonna
Well, we do have a movement break. We forgot about that. We have a movement break right now before our second session. So please go ahead. There's snacks and all of that. To start. That's a lot of people over there.
Oh, yeah. That's okay. I can also rally or like ask people to sit down if you'd like me to.
Yeah, go ahead.
What time do you want us to start, like within the next 2?
Yeah, next 2 minutes for sure.
Okay. And do I just have to get really close to it?
And you know what, it's okay because we'll be taking orders for lunch at the table.
Great.
So if we run a little over, that's
Doesn't
totally
matter.
fine.
Thank
I
you.
don't mind that.
Hopefully we won't. We've
Stress
planned it so like
Okay,
particularly, but I appreciate you.
Usually set up. Do you have your timer?
Do you want to put it like right here?
My phone is in my bag.
Okay.
I
Anyone
can go
else?
grab it. Do we have a phone on me?
Hello, everybody. This is our 2-minute warning before we start. Okay, everybody, it's about 2 minutes. There's still some chatter in the back, but we're going to get started.
Okay, go ahead, start.
Yeah? Okay. Okay, first of all, thank you so much for coming to the Parkinson Symposium. I know I speak for myself and my colleagues when I say it's an absolute honor to be speaking in front of you. I think most of the time our sessions are all done one-on-one, and that is always very satisfying, but it's always just as, I think it's almost even more powerful to get to share stuff we're really passionate to a big group. So, without further ado, we're going to get started. I'm going to introduce my colleagues. We're going to talk a little bit about an agenda before we get started, and then we're going to move into the good stuff during this presentation. Okay, so my name is Bryn. I'm a physical therapist. I've been practicing for 3 years. 2 of those years have been at UT Southwestern. I am a specialist in treating people with neurological changes, and I am also certified in POWER, which stands for Parkinson's Wellness Recovery, which we'll get into a little bit later.
So hello, sorry this mic has to come up for me, I'm too tall. So my name is Kelsey Galloway. I've been a therapist for about 2 years. I've been at UT Southwestern for about the last 8 months. Prior to coming here, I did a neurological residency for physical therapy where I specialized in treating patients that had various different neurological conditions. I did that at the University of Alabama at Birmingham before I came here. But very excited to be with you today and to be able to share this with you.
Good morning. My name is Jensen Chenankara. I'm an occupational therapist. I have been practicing for about 10 years now and have been at UT Southwestern for about 7 of those. And I have my brain injury specialty certification as well as my LSVT certification, which stands for Lee Silverman and Voice Treatment, which we'll actually talk about here later today.
My name is Mahesh Mahagave. I have been a speech pathologist past 20 years, and I have been with UT Southwestern for past 8 months. I'm certified in AMP Care, I'm certified in Vital STEM, and I'm certified in LSVT too.
Great. Okay, now that you guys know my team, we are going to talk about what you're in for. We're going to start with an introduction to the therapies. We're going to talk about PT, OT, and speech. We're going to go through some case studies for each profession so you can get a feel for what you might expect if you can identify yourself or one of your loved ones with any of the symptoms. We put in some community resources, although I see there's a lot of tables for actually most of the things we've mentioned. So please, if you haven't already, take some time to meet the lovely people in the back because all those resources are wonderful. We are aiming to save 15 minutes of this presentation for question and answer. That being said, when we originally got asked to do this presentation, we all went crazy and we were like, there's thousands of things I want to mention today. And we have halved it, quartered it, eighth it to this tiny presentation of just the surface level of what we can present. So please, if you have further questions that don't get answered by our presentation or the question and answer, come up and talk to us individually because that's usually what we prefer to. Okay, I'm gonna pass it off to Kelsey.
So everybody just take a second and breathe. You've been here very early. You've had a lot of information thrown at you, right? So take a second. Why are we all here? We're here because Parkinson's affects our daily life, right? That's the main thing we want you to take away. When we think about the therapies, the therapy team, that's what I want you to think about. So when you have this moment of, well, why should I consider therapy, speech therapy, physical therapy, and occupational therapy, what it comes down to is we want to provide education for you. And we also want to be able to give you tools that you need to help you as symptoms are changing, right? We know this is a progressive disease and we want to be proactive with that versus reactive. And part of that as well is we want to monitor your baseline symptoms. So what does that mean when I say baseline? Baseline is just a fancy way of saying where you are currently. I know for some of you, you may have just recently gotten diagnosed with Parkinson's. You may have had it for a couple months or a couple years. Whatever the case may be, we want to see you. And we ideally would love to see you as soon as possible because it's easier for us as therapists to track that change over time. Again, this is a progressive disease, so let's be proactive about it, right? And with that, we'd love to see you as soon as possible to be able to get a jump start on all of this and to help you with your goals as things are changing. And with that, I'm going to hand it back over to Brent.
Okay, so here we go. We're gonna start talking about what are PT, OT, and speech. So Kelsey and myself are gonna be the physical therapists talking to you this morning, although there's actually multiple neurophysical therapists in the back as well. What is physical therapy? Can you please raise your hand if you've done physical therapy before? Okay, that's a lot of hands. Can you raise your hand if you've done neurological physical therapy before? That's a few less hands. That's what I expected. I think a lot of people don't know that there's a specialty specifically for treating people with brain changes, spinal cord changes, balance changes. That's going to be our bread and butter. So what can a physical therapist help you with? Their job is to help you with your walking, is to help you prevent falls and improve your balance, help you maintain your energy. We know Parkinson's can drain your system. So we want to help fight that. It can help you in your transferring between surfaces. If you want to stand up, get off the couch. If you want to get up from the ground after something like gardening, those are our jobs to help you get better at doing. One of the big pieces of this presentation that we cut is what is some of the symptoms that we see in Parkinson's. There's so much, and hopefully these presentations and the ones that have come before us have been enlightening to you on some of the things to expect. But we're going to talk about just a little bit of the motor symptoms that we deal with more in Parkinson's and some of the non-motor symptoms that I'm going to leave for one of my colleagues to talk about later. So when I think of Parkinson's and the outside symptoms, you think of small, things getting small like your posture, your voice, your walking. You think of more imbalance, you can think of a tremor. There's also the non-motor symptoms that people know of a lot less. I think you guys in this room are probably more informed than most about what some of those non-motor symptoms are, but it can be anything from depression, changes in your sleep, changes in how you're digesting food, or even how you're sweating. There's a lot of unique symptoms. And if you get one random symptom, maybe it's worth talking to your physician or looking it up and being like, could this be related to my Parkinson's? So as someone experiencing these symptoms, what should you do? Obviously, I'm biased, but I'm going to tell you, you should get physical therapy. One of the biggest questions people come to me with is they're like, hey, Bryn, okay, so I'm here in physical therapy, but like, what are we actually going to do? We're going to work on these 4 main areas. This is what's most supported by research. So those 4 areas are aerobic training, strength training, balance training, and flexibility work for people with Parkinson's. I put a few slides in here from the Parkinson's Foundation. Again, they have a booth in the back. They are a huge organization in the research of Parkinson's, but definitely worth looking into if you have more questions. Okay, so my job here is going to be talking about those 4 categories. The first one, aerobic training. What is aerobic training? It's also called cardio. It is not the same thing as, hey, Bryn, I went to the park and I kind of had a little stroll. That's not cardio. That's a good walk, and it's definitely a great place to start. But my job would be to help you find a way that you can get your heart rate and your breathing up. If your heart rate and your breathing are not up, it's too easy. Reason being, there is an abundance of research in Parkinson's on high-intensity aerobic training. Specifically, the part of your brain that activates when you do high-intensity training is the same part of your brain that activates when you take your carbidopa-levodopa or your Sinemet, your Parkinson's medications. So what does that mean? You do aerobic training, and then your symptoms will actually decrease. It's going to be for a short time, but if you become a lifelong exerciser, if we can find a way to help you get into exercise as something you commit to for life, we can impact and potentially halt some of your symptoms for life. Okay, moving on. Stretching. Everyone's somewhat familiar with stretching. There's a lot of ways to stretch. Some of that can be lying down or standing or sitting. Why is this important? Stretching is important because it can help you manage pain that can come with Parkinson's disease. It can also help you maintain your mobility. So if you're having trouble maybe lifting your shoulder and grabbing something from the top of your closet, maybe your shoulder needs some stretching. There's a lot here that I'd love to delve into, but I won't talk your ear off on this topic. Next one, strengthening. Strengthening is what people are most familiar with, I think, when they think of physical therapy. And I purposely put a million random little exercises on this slide because I wanted to show you, you can do it in pretty much any position. The job of your physical therapist is to specifically figure out which muscles you're weak in, help you figure out the exercise that you can perform at any mobility level that you would be most likely to actually perform at home, and then incorporate that into helping you get towards your specific goals. So I mentioned gardening before. I feel like that's a pretty common one for people to come into me and be like, Bryn, I really want to get back to gardening. Well, maybe I throw 3 different exercises at you specifically for gardening. One fun thing that I always like to mention when I talk about strength and PT is this bottom right exercise. It's the lady standing from the chair. Raise your hand for me if you've ever had to do a sit to stand before. Right? Why is that every physical therapist's favorite exercise? I can tell you. It's because it's super functional. You activate the same muscle groups that you use when you practice a stand as when you're trying to walk upstairs or get up from the ground or get off the couch. So specifically, we try to integrate strength with function. Okay, balance training. Balance training is complex. The number of my friends with Parkinson's that have come to me and been like, Bryn, I wanted to start working on my balance, so I looked it up on YouTube, and YouTube said I should work on single leg balance, and then I fell. I'm like, okay, well, we should start somewhere else. We can't listen to YouTube all the time in our balance training. Balance training has a little bit of a barrier to get into. I think people don't know how to start it in a way that'll actually be effective. My job would be to help you figure out an easy way to start practicing it, just to introduce your body to the concepts. And we work and we progress it. So hopefully you either stop falling or don't ever have a fall, or your falls decrease in frequency. Okay, there's so much more to this presentation. Thank you for your ears so far. I'm gonna pass it off to Jensen because we'll talk about a few more topics physical therapy related in our case studies.
Thank you, Bryn. So yes, I will be talking about occupational therapy. How many of you guys have heard of occupational therapy? Awesome. It's always like the one therapy that most people don't know about. They either think that we're here to help with getting a job or just, getting back to just doing that. And so I'm glad that y'all have heard of it. So occupational therapy, our goal is to help with improving your health, your well-being, and your overall participation in the things that you do every day. And those activities are what we refer to as occupations. And so occupations can be as simple as things that you do every day for yourself, those self-care things like brushing your teeth, taking a shower, And it can go all the way to leisure activities, gardening, going back to work, things in the kitchen. So all those things that we do are involved as occupations. So how does Parkinson's affect daily life? And so just like Bryn talked about, there's so many different symptoms when it comes to Parkinson's. And when we look through the lens of occupational therapy, there are a few things that we are looking at. One is just that slow movement, especially whenever you're looking at your upper extremities, what we call bradykinesia. The other one is called rigidity, where you might feel some of that stiffness that's going to prevent you from moving as fluidly as you might have done before. Tremors is also a huge part of Parkinson's, and we'll kind of talk a little bit more about that in depth when we get into our case studies. And that is what decreases some of our fine motor coordination, where we have trouble with manipulating things in our hands, whether it's counting coins, sorting clothes, anything that involves just really small, precise movements of our hands, as well as visual changes. So a lot of people will complain of blurry vision or double vision, which is going to impact your ability to participate in things at home and in the community. And then we'll also talk a little bit about mood and cognitive changes, so depression, anxiety, as well as just your overall ability to remember things, as well as problem solving. And then balance as well. So both sitting and standing balance can be affected in Parkinson's. And that's important because we need our core, we need our leg strength in order to do the things that we do, whether it's standing to take a shower or to make a meal. So when we think about our interventions, there's 3 different buckets that we kind of look at. So the first one is more of that restorative therapy, where we are trying to help with improving your function or regaining some skills back. And just like Bryn talked about, exercise is a huge part of that. And so we want to help engage and empower you to teach you exercises that you can work on in order to improve your strength, improve your range of motion, so that you can participate in the things that you need to do. The second bucket is more of that compensatory or ways to kind of adapt to your environment, or maybe just using different tools or strategies so that way you can still participate in the things that you do, but it might just look a little bit different. And then the third bucket is more self-management skills, and we'll talk a little bit about this here in the next few slides. These are more just coping strategies and just regulation strategies to help you with just engaging in your environment in a more successful way. I'm going to take a second and just talk about mental health and emotional well-being, only because this is a huge part of Parkinson's and sometimes one that we don't really address as much as maybe the motor aspect of it. But depression affects about 50% of people with Parkinson's. And some researchers believe that depression is due to some of the brain changes that happen and the chemistry in our brain. And sometimes those things happen even before you're diagnosed. Some Parkinson's medicines also have antidepressant effects of its own. And antidepressants can also have their own side effects and can have different reactions to other medications that you take. And so it's very important that you're having that ongoing conversation with your doctors if you're experiencing any of those symptoms, so that way they can adjust any medications that need to be made. So the reason why we kind of talk about mental health and occupational therapy is because our bread and butter is just engagement and participation in the things that you need to do every day. And so people with Parkinson's experience lower levels of engagement and excitement while completing those things that you need to do. Maybe things that were so easy for you to do before, like going to the grocery store or even engaging with your grandchildren. That can be very challenging, especially when it takes a lot more effort for you to do. And so it's very common for people to kind of withdraw and just be more isolated and just kind of avoid some of the things that you enjoyed doing before. But that's where we come in, because we don't want you to think that your life is over because of this diagnosis. There's still ways to participate, there's still ways to engage in those activities, and some of it might just look a little bit different, but we want to help you with creating different roles and routines for yourself, different structures, and using different strategies to feel empowered to do those things. And of course, that's where our friends in psychology and social work come into play as well. That is where they're also very much trained and specialized in. And so if we ever felt like that is something that you would benefit from, whether it's just counseling or support groups or different medications, we would want to refer out to them in order to give you the assistance that you need. So just like I mentioned earlier, OT's role in mental health would be helping to create different routines for you. So creating structure helps with eliminating some of the confusion or the anxiety that comes with maybe doing things that just seem really more complex now, as well as helping you to modify activities. We are so good at that. So that can just mean whether we're using a different tool or maybe you do something a different way. We want to help make things less burdensome for you so that way you feel like you can still do those things that you need to do. We are also able to help you with just learning healthy coping strategies, whether it's meditation or taking a walk or journaling, anything to help you with having good strategies in that time to know that you don't need to get stuck in that place, but there's ways to kind of work around it and do the things that you need to do. Cognitive movement strategies. So this is just a really fancy way of saying, how do you break up a really complex task, such as making a meal, and break it up into really simple steps? Our brain likes that, so that way it doesn't feel as overloaded. Sometimes just using this concept of mental practice or kind of thinking about it in your brain before you do it helps to kind of prime the brain or warm it up, so that way you feel more ready to do those things. And with that, I'm going to hand it over to speech therapy.
All right. How many of you did speech therapy here? What does speech therapist do? My managers over here, they think we just talk. We don't do anything but just talk. Okay, so as a speech pathologist, we focus on communication skills, swallowing skills, and cognitive linguistic skills. The cognitive linguistic skills include memory, attention span, and processing speed. The thought processing. Usually the thought processing is slow in Parkinson's patients. We focus on safety, independence, and quality of life in Parkinson's patients. So 90% of the people with Parkinson's develop speech and voice disorders, and 80% of the people have dysphagia or the swallowing difficulty. It's always better to have early intervention because it improves the communication effectiveness, it improves the nutritional status of the patient, and it improves the quality of life. The common changes that you notice in Parkinson's is you have very reduced loudness. It's called hypophonia. Sometimes you can't even hear at 1 feet or 2 feet. And the speech is very monotonous. So there's no intonation. The speech looks very flat. And there would be slurring of speech. Slurred speech could be at the word level, or it could be at the sentence level, or during the conversations too. And the speech rate could be either fast or slow. And there is reduced breath support because of the weakness in diaphragmatic muscles. And there could be vocal fatigue secondary to weakness in the laryngeal muscles. So what we do as a speech pathologist is we measure loudness, how loud the Parkinson's patient can be. We use the sound level meter or dB meter to measure the loudness. We assess different types of breathing patterns because some people use the clavicular breathing. When you use clavicular breathing, you get exhausted very easily. And some people use abdominal breathing, and some people use thoracic breathing. And we measure the speech rate because the speech rate is sometimes it's very slow, and sometimes it could be too fast too. So we measure the speech clarity, and we look at the voice quality too. Because when they speak, you have a lot of breathy voice component. So we need to look at that too. So we give them the formal testing. The formal tests are Newcastle Dysorthy Assessment Tool and Colorado Motor Speech Framework and Voice Handicap Index. So these all tests measure the speech intelligibility scale, and the Colorado Motor Speech Framework we can differentially diagnose what type of dysarthria you have. The goal of speech therapy is to achieve and train your ability to identify just right level of loudness and clarity. So what we try to do is we give vocal strengthening exercises. We use Lee Silverman voice treatment. This is a very intense treatment where the patient has to come 4 times a week for 4 weeks, and we work on voice and loudness over there. And there's one more technique called speak out, and we teach them various speech strategies, like there is acronym called STOP. So when they speak, we teach them to slow down, talk loud, over enunciate things, and pause in between the words. That would help them to speak clearly. And we work on diaphragmatic breathing, because we teach them the diaphragmatic strengthening exercises, and we work on diaphragmatic breathing that improves the speech intelligibility. And if the patient doesn't show enough improvement, if the patient's speech is very slurred, we refer them to alternative augmentative communication, okay? They can use the different apps to communicate the needs, okay? Here are some of the communication apps you see. It's called Speak Up for Parkinson's. It's a free, friendly user app. And Understand Me for Life, App to Speak, DAF Professional, and Parkinson's Speech Aid. Here comes the most important component. With Parkinson's, you'll end up having a lot of swallowing problems. It's called dysphagia. Usually, you tend to see the patients tend to cough or choke. Sometimes they complain that food is stuck in the throat. They are slower in chewing because of the weakness in their cheek muscles. Sometimes they drool, and sometimes the food escapes from the mouth because of the weakness in the lip muscles. And they have difficulty in starting to chew and swallow because of the weakness in the tongue and weakness in the laryngeal muscles. They have tongue weakness and discoordination. All these problems lead to aspiration. Aspiration is when they chew and swallow, the food is not going into the food pipe, but it is going into your windpipe, and it goes into the lungs, and they can end up having pneumonia. And it leads to malnutrition and dehydration. As a speech pathologist, when we do the evaluation, we do the clinical swallow eval. We test the various muscles like lip muscles, tongue muscles, and laryngeal muscles. If we suspect any aspiration, then we refer them to video fluoroscopic swallow study. In this test, what we do is we give barium to the patient, and we ask patient to swallow the barium, and we see whether the patient is aspirating or not. This test is very important because it tells where exactly the lesion is. Based on that, we can structure our treatment sessions. And there's one more swallow study called fiber optic endoscopic swallow study. This takes usually 20 minutes. And in this test, what we try to do is we pass the camera or scope through the patient's nose, and we look at the anatomy and physiology of the swallow, and we look whether the patient is having any aspiration and how his laryngeal muscles are working. Coming to swallowing treatment, so we teach the Parkinson's patients with dysphagia the effortful swallow, or Mendelssohn's maneuver, or chin tuck against resistance. These all exercises try to strengthen the laryngeal muscles. We teach them various compensatory swallowing strategies, like after every swallow, we ask them to take 2 swallows after every swallow and drink liquids after every 2 bites. That would help. And sometimes we work in coordination with physical therapists to make some postural changes that would help to swallow better too. We do diet modifications, like if the patient is not able to swallow the regular textures, we downgrade them to mechanical soft or minced moist, where you blend the food and make it soft, or we downgrade them to pureed. And sometimes we try to test them on thin liquids. If the thin liquids travel too fast, if they tend to cough or choke, then we thicken their liquids. Then we provide mealtime education for the patients and their families, and we collaborate with the medical team, and we collaborate with the dietitian for optimal nutrition. NEMS, this is very important. This is neuromuscular electrical stimulation for dysphagia, uses low-level electric current to stimulate muscles and nerves in the neck and throat. So what we try to do over here is we place the electrodes on your larynx and we try to strengthen the laryngeal muscles. And it helps to pull the hyoid bone so that it prevents aspiration. So we have different types of NEMS. I'm going to talk about that. This helps to improve muscle strengthening and functional improvement. It improves the swallowing coordination and endurance. It mainly helps to protect your airway. It increases the sensory input and motor control of swallowing. The picture that you see on the right is amp care. These are the small electrodes that we place on the neck. And the picture that you see on the left, that is like vital stem. This helps to strengthen the buccinator muscles. Sometimes it helps to control the drooling too. Okay, coming to cognition, you see a lot of cognitive changes in Parkinson's. There are deficits in attention span, there are memory problems, they have deficits in executive planning, they have a lot of word finding difficulties, and the processing is very slow. So in order to test the cognition, we use Addenbrooke cognitive examination, we use prompts. And we teach them various strategies to cope up with the memory. Like the example is RAP, like write, repeat, associate, and picturization. My name is Mahesh, and most of my patients can't remember my name because it's a foreign name. So I asked them to remember my hash browns. So they can remember my name, Mahesh, so that really works. When you try to associate things, it really works. So we help them to practice to improve thinking for daily activities. Now I'll hand it over to Kelsey.
Thank you, Mahesh. So we're going to get into the case study part of our presentation. So I'm going to start for physical therapy. So I'm going to present you with a patient example. So Mark is 56. He's been diagnosed with Parkinson's for about 2 years. He has noticed recently that he is having a harder time keeping up with his coworkers at work. He feels like they're walking way too fast. He also feels like he's stumbling too when he's walking. His wife is noticing that he is starting to kind of stoop forward. He was a tall guy, now he's doing this versus being upright. And so there's some things that she's starting to notice and things that Mark is starting to notice as well. And Mark is coming to see physical therapy because he wants to work on his balance and on his walking. So if Mark came to see me for the first time, what are some things that as a physical therapist I would look for? So the very first thing is I'm going to evaluate his balance. Regardless of Mark not having any falls, I'm still going to look at what's going on there. I want to understand why he is stumbling. Is it because maybe we have an issue with how we're walking? Is it because we have muscle weakness? What exactly is going on? And so part of that is what's happening with his balance. I'm also going to look at his walking speed. So how does that walking look? Are we doing small, shuffled steps, which is what I would expect to see in Parkinson's? Or how is that changing? Another big thing I would look at is strength. With strength, one thing in particular that, as we've been doing this for a long time now, we kind of know certain things to take a peek at. One of them is called drop foot. So it's when the muscle on the very top of your foot begins to become weak. And so when you're walking, you start dragging your foot. And that's kind of a telltale too, that maybe we're having some stumbling because of that drop foot, or maybe something else is going on. So these are things that I'd look at with him, as well as coordination. With Parkinson's, coordination is one of the biggest things that's affected, and I would expect to see some deficits there. So what exactly is coordination? Well, it's your ability to do a multi-joint movement. Meaning, for example, if I move my arm, my shoulder, elbow, wrist, fingers all have to coordinate that movement for me to grab a glass of water, grab clothes off of a coat hanger, whatever it is. And sometimes those movements are difficult, and it can also affect our walking and other things that we're doing too. So I take a peek at that. So things that I would work on with Mark that we would target would be number one, right, his walking. He said he wants to improve his walking. We're going to work on that walking. And we're going to do that through something that's called large amplitude movements, which means we're going to be doing really big, large movements to help him as he's walking. We're also going to work on his posture training. Just like Mahesh mentioned, posture is not just important for speech, but it's also important for our balance and for our overall mobility. We need to address that and work on it. We're also, of course, going to work on his balance and fall prevention. Again, just because he has not had a fall doesn't mean that's something we don't have to worry about. We need to be proactive, not reactive with things. We're also going to focus a lot on functional movement. As Bryn talked about before, I'm a big believer, we are with therapy, that we want to do things that are important to you and things that you do every single day. So it's going to be functional. I'm not going to ask you to do a bicep curl, sit there, lift weights, because I think it's great and wonderful and we're strengthening. No, I'm going to ask you to do things that are important to you. So practicing maybe getting on and off the ground, maybe kneeling, maybe getting in and out of bed, things like that to help you reach your goals. And we're also going to be focusing a lot of time on dual tasking, which is the ability to do more than one thing at once. Best example I can think of is when you're cooking dinner, and let's say you're cutting, doing whatever you need to do, you're talking on the phone to somebody. You're doing two things at once, right? Or same thing, you're driving in the car, you're having a conversation to the person that you're talking to in the car. That requires an intense amount of cognitive concentration, right? You're doing a lot of stuff happening. And we see with Parkinson's that becomes very difficult. So we got to be able to handle that and approach that with therapy. The big thing that you've probably heard me mention more than once, and we've all kind of alluded to, is the balance. So why do we care so much about balance with Parkinson's? We care about it because research has shown that when we improve and work on balance, not only, surprise, surprise, is it going to help with balance, but it's also going to help with your walking speed. And it's also going to allow you to improve your ability to do that dual tasking, which I mentioned previously. And so why do we care about walking speed? We care about it because research has shown that anybody who walks less than 2.2 miles per hour, which again, I'm not saying I need you to go find one of those little speed traps and run in front of it and see how fast you can go. That's our job to find out for you. But the research shows that if you walk less than 2.2 miles per hour, you are a falls risk, which that also comes with you're more likely to be hospitalized. And you're more likely to rely on caregivers and family to help you with your activities of daily living. And I don't say this to scare you or alarm you. These are things as therapists we look at because we want you to be independent and functional. We want you to be able to be as independent as possible, and we want you to have a great and wonderful life, right? We want you to be able to do the things that you want. And so part of that, when we think of walking and things that can help you do what you want to, is assistive devices. So for Mark, he is stumbling. Maybe in the beginning, he might need a cane or these beautiful trekking poles, which I did see someone earlier have a trekking pole, so fabulous. But maybe he just might need a little bit of help in the beginning. But over time, things can change. So he may have to start using a rollator because he needs a little bit more support and stability. Or maybe he needs a rolling walker. It's a little bit more sturdy to help him out. And something that is very unique to Parkinson's is what's called the U-step. It's these bottom two pictures over here. That's something that a lot of our patients with Parkinson's have, and we've seen it more than once. It's kind of like the Cadillac of the Parkinson's world. If you have Parkinson's, you got a U-step. It's kind of a specialty club. But that's a device that can help you to kind of assist with walking and getting around where you need to. Again, different devices are used at different times and for different things. Just because you may be having an issue with your balance doesn't mean we have to go straight to a walker. There's other options out there. So don't feel like this is limiting you in any way. A lot of what we do with physical therapy is we're creative in how we approach changes. And I'm going to hand it over to Bren, but she's going to talk about something that's unique to walking.
Okay, here comes the next little part for physical therapy. We're almost done with the physical therapy part, and at the end of this, I'm gonna ask all of you guys to move for a second, so bear with me. Freezing of gait. This is a symptom very unique to Parkinson's. Not everybody knows they're doing it until we kind of talk about it, but some people may notice it before they come to me. What is freezing of gait? It's also called festination, but it means when you're walking, your steps start normal, and then something triggers the brain and your steps start getting smaller and smaller and smaller until they stop. Well, your momentum doesn't stop, so your body may still go forward and you may have a fall, but your feet are stuck there, and it's like, why aren't you moving? We're gonna talk. If you were my patient, I would walk you through what causes it and specifically how, like, what strategies for you can use in those moments to get out of it, and we'll go over a few in a moment. What are some common causes of freezing of gait? I put 3 here. The most common one I see is doing 2 things at once. It's probably been a long time since someone's asked you to pat your head and rub your tummy. But anytime you're, like Kelsey said, if you're on the phone and you're also chopping veggies, or if you're talking to someone on the way in through the auditorium, those could be examples of times where people may experience a freeze. Maybe for you, it's when you're walking between really tight spaces. That could be a doorway, or maybe you're walking in a parking lot, you're walking between 2 cars, and boom, they're just too tight together, and you're frozen. I would love to delve into this more, but I want to talk briefly about some strategies. Some of the cool strategies we like to use are going to be more internal. Maybe that's, I have you count when you notice you're about to go through a doorway. Or maybe for some people, they're doing a prayer while they walk through because it keeps their mind focused internally instead of on that external doorway. For other people, we use external cues. I put a little picture of some tiles, but if you're walking in through the auditorium and there's tiles on the ground and you're frozen, maybe that means you look at a tile and you try to step big to the next one. Or, like Kelsey alluded to, there's a picture of that U-step walker in the bottom right side with a little laser attachment. That laser attachment is one of the reasons why we like the U-step walker for people with Parkinson's, because it can be a cue for you to step forward to instead of staying in that freeze. This is where I made a little bit of a mistake. I was hoping to give you guys a picture of power, but I sent over the wrong PowerPoint slide, so I'm sorry in advance. But the good thing is now you guys are all stuck moving with me a little bit. So I'm going to walk you through one of the power moves exercises. I actually see a few of my own people in the crowd that I've seen and introduced these to. This is twofold. POWER stands for Parkinson's Wellness Recovery. It is a community organization actually out of Tucson, Arizona, where they work really hard on educating people on Parkinson's, the up-to-date research and making sure they spread that to both like people with Parkinson's, their caregivers. They also do cool retreats where they invite everyone onto the campus for 7 days and they go through all of the latest research and go through exercise. My patients that have gone loved it, but please talk to me about it afterwards if you have any interest. The other piece of POWER is that it's actually a protocol that combines those 4 pieces of physical therapy into one home exercise program. So that's strength, balance, aerobic training, and flexibility. We combine those all into one little protocol. This is where I was hoping to have that picture, but okay, I'm gonna act out the first power exercise. If you would like to stay sitting while you do it, feel free. If you'd like to stand and do it, feel free. Just don't whack the people next to you. I'm gonna have to stay near this microphone as we do it, but step 1, when I act it out, I would ask you to stand with your arms super wide. Go ahead and stand up. I see a few people going for it, why not? If anything, it'll just help you pay attention for the rest of our presentation. We're almost done, I promise. Okay, arms wide. Please don't whack anybody. I want you to bring your arms together. So you're gonna bring your right hand to your left hand in a clap, and then you're gonna open back wide, and then we're gonna go to the other side. Clap and wide. You should feel a little stretch in your back. You should feel a little bit of a balance challenge, and if you don't, that's okay, we can make it harder. We're gonna go through 5 of them. If you were one of my patients, I'd probably make you do over 1,000. But you guys are lucky today, we're only going through 5. So here we go, we're going to the left first. We're gonna close and open, close and open, close and open. That's only 3, close. That's 4, close and open. Okay, you made it, that's 5. Okay, Last little piece of physical therapy. You guys can all have a seat. Thank you very much for standing. Sometimes when you get up in presentation mode, you're like, are people actually going to do it with me? You guys have made me proud. I'm going to pass it off to Kelsey to talk briefly about family impact in Parkinson's before we pass it over to OT. Thank you.
Thank you, Bryn. So obviously, right, the symposium is not just for patients, it's for family, for caregivers. And so part of that with therapy, we have patients that come in to see us, again, at different stages of Parkinson's. We understand that family and caregivers play a very huge piece in that. And often when family and caregivers come in to meet us with their loved one or with their friend or whatever the case may be, we talk a lot about things that we can do to help make your life easier as well. And for some people, it is teaching you how to do transfers, how to get your loved one in and out of the car, how to get them in and out of bed, maybe how to help them when they're getting in and out of the shower, things like that. We get creative with how we can help you do that job, right, when you need it, as well as how to manage assistive devices. I am under no illusion in trekking poles. Goodness, when we teach someone how to use it, it takes a little bit of time. And the same thing with some of this other equipment that we showed previously. So that's our job to help you. We don't expect you to know everything. So please don't think when you come, you have to know everything. That's our job. We went to school for it. Y'all can take a break on it. Let us do the heavy lifting, okay? Part of that too is we also are educating, right? We're empowering you as the family, as the caregiver, to understand things to recognize and to be aware of. And part of that can be freezing. Maybe the person that is freezing doesn't realize it's happening. And I've had a lot of family members say, you know, you're freezing right now. What did your therapist say? What are the things we need to do? And sometimes having an extra set of eyes is helpful, right? So that way that you can also assist and help in navigating things, or knowing what cues are helpful for that person as they're embracing these different challenges and things that are happening. And part of that is too, you are with that person way more than we are. Yes, we may see you once or twice a week for maybe 45 minutes, but you're ultimately with them a lot more. So we value your input. You are our eyes and ears at home. We want to know what you're seeing and what's happening. Tell us that, because we don't often see what's happening all the time. And unless you tell us, we don't know. So we value your input, and we want you to know that we're part of your group, your team, to help you. Something that's also unique to therapy, all of us as therapists, is we're kind of, I call it the bridge. We can help bridge the gap between you, your neurologist, and your primary caregiver. We want you to see all three of us, regardless of if you're not having speech difficulties or you're not having issues with, fine motor movement, whatever the case is. Please come and see all three of us. Again, get that baseline established, so when things change, we know what to do. We can also help recommend referrals to a nutritionist, to psychologist, psychiatrist, as well as urologists. The last one, some people go, why is that being talked about? It's a common issue, and it's nothing to be embarrassed about. And sometimes in therapy, we talk about a lot of different things. And so that's something that we can help kind of bridge the gap on. And we can also help get you in touch with your neurologist a little easier if you're noticing changes in medication, as well as if you need a different assistive device. So again, use us, we're your bridge, use and abuse us, right? We're here at your disposal, let us help you.
All right, so moving on to case number 2. Lewis is a 60-year-old male, and he's had Parkinson's for about 8 years. He's starting to have some difficulty using his hands for things like dressing, buttoning, and making meals. He's also noticed a resting hand tremor in both his hands, and it gets worse with stress and fatigue. He's also reported some challenges with writing, to the point that he's starting to not be able to read his own writing. He's also noticed some rigidity in his right shoulder, and he also gets very tired quickly, and he has to take naps throughout the day. He's also been complaining of some blurry vision and has often tripped over socks and shoes when walking around at home. So if Lewis were to come and see me for an OT evaluation, there are several different things that I want to look at. From based on what he asked or told me and things that I know about Parkinson's, one of the big things I want to look at is his range of motion. And so I'd want to evaluate and see what his movement looks like, if he's having any rigidity, if he has pain with his movement, and getting a measurement of where that movement is at that point. I'd also want to look at his strength. And so I check his strength in his shoulders, but I'd also want to check his grip strength, since he mentioned some trouble with some things with his hands. And then I'd also want to look at his fine motor coordination. And so there's some assessments in our clinic that we can use to get a more standardized assessment and some measurements of how quickly he can take these pegs in and out of a box, and some other assessments that we can use just to get an objective number in order to create a baseline. And I also want to do a quick screen on his vision. I am not an eye doctor, but as part of OT, we can also do screens on both vision, like distance vision as well as near vision. We can look at the ability to identify like the background from the foreground. So if you think about like a black cup on a black desk, it's going to be kind of hard to see. So just kind of seeing his ability to notice those things, because that's going to impact his ability to do the things that he needs to do. So based on that, I would start our treatment interventions. And so I had mentioned LSVT earlier. So this is another program kind of similar to the POWER program that Bryn mentioned. It's a very intensive protocol that is multidisciplinary. So OT, PT, and speech do this. It is also 1-hour sessions that we do 4 days a week. And the biggest emphasis on this is large movements. And so just like we mentioned before in our presentation, one of the biggest symptoms of Parkinson's are those small movements. And so we want to help with retraining those small movements into those large movements. And so all of those exercises focus on big movements, not only with the arms, but with your trunk, with your legs, in order to help with regaining strength, mobility, flexibility, and coordination. And this is also where we slacked on our picture, so excuse us for that. The second thing that we want to look at, since he mentioned some difficulty with his hands and some of those tremors, I'd want to help with addressing that. Tremors affect about 80% of people with Parkinson's, so it is one of the more common motor symptoms that you'll notice in the disease. One of the first things that you might notice is a resting tremor that just kind of happens when you're just sitting still. It usually happens in your hand, one-sided. Tremors can also happen throughout your body, but it tends to be that you notice it more in your upper extremities. There's also another type of tremor where you're kind of like rolling your fingers between your thumb and your index fingers, so that's called a pill rolling tremor. And it can also intensify with stress and fatigue. So just like we mentioned earlier, a lot of these things that maybe have been so normal and easy to do before can tend to be a lot more challenging now. And so then you add in that stress and fatigue, the tremor increases, you get more stressed, and it's a vicious cycle. There are some interventions that we can do with tremors, and so one of them is called proximal stabilization. So that's just a fancy way of saying, how do we help with stabilizing our shoulder, our upper extremity, so that we have more control of our hand? So that looks like, let's say you are trying to cut some food, and I think we all grew up with the manners of not putting our elbows on the table, but in this case, I'm giving you an excuse to let you do that. Sometimes letting your arm rest on the table gives that arm the ability to just rest, so that way you're able to control more of the utensils that you're using with your hand. So you'll notice that you're not having to work so hard to hold all of that up, so that way you're able to have the control that you need for some of those finer movements that you do. Another compensatory strategy or another adaptive thing to think about is just different types of clothing and adaptive equipment that's out there. This is just a list of different companies and organizations that actually provide different kinds of clothing and different tools that are more adaptive. And so there's magnetic front shirts, so you don't have to worry about buttons. There's bras that you can get that you don't need to worry about the hooks. There are tools out there to help with makeup to where you're not having to work so hard to hold and control. So there's so many things out there that can make your life easier. There's also different adaptive equipment, and that would be something that we could talk through when you're here in therapy with us, are different adaptive equipment tools that might be beneficial. To the far right, you see a picture of a button hook, and so that's just a tool to help you with getting buttons on maybe a little bit easier. There's also things for shoes, so no-tie shoes as well as Velcro shoes to avoid the challenge of having to tie those shoelaces. We all know that can be very difficult at times. Another thing that we'd want to emphasize with tremor management is just relaxation strategies. As we mentioned, the stress and anxiety can increase and worsen the tremor. And so things we can teach you are some strategies like breathing strategies or relaxation strategies before you do it to kind of get your brain relaxed and helping you to be a little bit in a more calm and peaceful manner, so that way you can do those things without getting as anxious. Micrographia, so that is just really small writing. And so you can see on the far right an example of this. This is also a very common symptom with Parkinson's. You might notice with this that your letters start to get really small, or maybe you start writing pretty normally and then it gets smaller and smaller to where it gets illegible. And then the overall effort to write is also very fatiguing for you. So some things that you can practice with that, we had talked about that mental practice of how do you kind of do it in your mind before you do the actual motor task of it to kind of prime your brain. So practice with your eyes closed and just kind of think about what you're going to do, or write it in the air and really focus on those really big movements. Another thing to kind of warm up your hands are finger flicks, so just kind of getting those fingers warmed up. And then also adaptive strategies like wide ruled paper or weighted pens to help you with decreasing some of the tremors. The next thing that we would want to focus on would be just environmental modifications. So in Lewis's case, he was having some trouble with walking around the home. He was tripping over socks and shoes. And this can be a really big issue with really any older adult, but especially with those with Parkinson's. Just like my colleagues mentioned, with Parkinson's progressing, the balance can get worsened. Your walking might be a little more challenged. And so making your home as accessible and safe for you is super important. We want you to thrive at home. We want you to feel comfortable there. We don't want you to not get up and move and go to the bathroom because you're worried about a fall. And so we can help with kind of identifying maybe some barriers or some obstacles that might be making those things a little bit more challenging. And some of them are as easy as clearing your pathway, making sure you have enough lighting at your house, making sure you're securing cords or different wires, removing rugs, and then even the use of color tape. You can use that on the edge of a step to help you with identifying the front part to avoid any trips on the staircase. Fatigue. So fatigue is just an overwhelming exhaustion that doesn't go away. It's also one of the more common non-motor symptoms that you might experience in Parkinson's. It's not just your body's reaction to what you're going through or even just because you didn't get enough sleep, but the result of the brain changes that are happening. And it tends to happen pretty early in the disease, and it can be due to just lifestyle changes. Maybe you're becoming more sedentary. It can be due to the medications you're on. And then akinesia, which is just the trouble in doing activity. Something that you used to do that was very easy and automatic now requires a lot more effort, and so it just takes a lot more energy from you. So some strategies that we can talk through with you are just the 4 Ps, as we call them. Prioritize what's most important for you to get done. Have a plan of what you want to do. Pace yourself, making sure you're taking breaks throughout the day. And then positioning. So how are you positioning yourself and using proper body mechanics so you're not overworking or overdoing anything. And then the last part of it would be sleep hygiene. And so making sure that you have a good bedtime routine, that you're keeping it consistent, that where you're sleeping is cool, comfortable, and dark. And then also limiting your screen time and then food and caffeine intake a few hours before bed to help you with getting the optimal sleep that you need. With that, I'll hand it over to speech therapy.
All right, coming to speech case number 3. Carol has been diagnosed with Parkinson's for 5 years. She has noticed that her speech is softer, causing those around her to have challenging time to understand her what she's saying. She have noticed that she's coughing when she's drinking liquids, and she complains of food getting stuck in her throat. So as a speech pathologist, what we could do with Carol is first assess her loudness, clarity, and speech rate and intelligibility, and see how her breath support is and how her vocal endurance is, and her impact on daily communication and participation. And based on this, we can do the Newcastle Dysarthria Assessment tool. We can use it, and we can use Voice Handicap Index. This really helps. So trust me, I have seen a lot of Parkinson's patients where they were inaudible, even at the distance of 1 feet. After the speech therapy, I could hear them at 5 feet. This really helps. And coming to swallowing assessment, we did the clinical swallow eval. Like we tested various muscles. We could do like tests like lip muscles, tongue muscles, and laryngeal muscles. And we can test various food textures like regular, pureed, mechanical soft, and see how she does on it. And if we suspect any aspiration, then we could end up doing the instrumental testing. We can do the modified barium swallow study or FEAS to rule out silent aspiration. So the goals of speech therapy for Carol would be improve voice loudness and speech clarity, and reduce coughing and choking episodes, improve swallowing safety and efficiency, and maintain appropriate nutrition, hydration, and quality of life, and support independence and reduce caregiver burden. Coming to speech therapy interventions, we can use LSVD loud or loudness-based therapy. This really helps. It is a very intense program, and this really helps the patient to speak loud, and the speech becomes really clear, and you notice the difference within 4 to 6 weeks. And we work on breath support. The diaphragmatic exercises and diaphragmatic breathing is very important. So we try to strengthen the diaphragmatic muscles. And we teach them how to coordinate between your respiratory and speech, because the respiratory system is very important to speak very clearly. And we work on rate control, and we work on articulation strategies. Like we give them various tongue exercises and ask them that makes their speech clear. And we practice like carryover during functional conversations. With Carol, we can teach the swallowing exercises like effortful swallow or Mendelssohn maneuver. This helps to strengthen the larynx. And we can work on postural strategies and calm strategies. And we can work on diet texture and liquid modifications. And we can use the vital stem or amp care to strengthen the laryngeal muscles. You can see the vital stim tool over here, and we place the electrodes on the larynx and we give the electrical stimulation. This is vital stem. And this is amp care. This is the other tool where we can provide the electrical stimulation to larynx. So, impact on family and caregivers. Parkinson's is a progressive condition that affects not only the patient, but the entire family. It increases stress, anxiety, and fatigue due to communication breakdown. The research shows there are higher rates of burnout and depression even among the caregivers. Role changes happen within the family, where your spouse becomes a caregiver and where your child becomes a caregiver. It adds a lot of burden on them. And swallowing difficulties increase caregiver responsibility at meals because they have to supervise during the mealtime because they can end up choking. And there's a need for modification of diet and supervision, because if they can't chew the regular food, we need to downgrade it to mechanical soft and make the food very soft. And we have to thicken the liquid sometimes if they cough or choke on thin liquids. And there's a fear of frequent hospitalizations for pneumonia because of choking and aspiration. And sometimes the changes in memory and attention can be misunderstood as lack of effort on patient. Bottom line, the speech, swallowing, and cognition changes are core symptoms of Parkinson's disease. Speech therapy is very vital in helping Parkinson's patients to maintain their communication, swallowing, and cognitive linguistic skills and to promote independence. Speech therapy is very essential across all stages of Parkinson's disease. It's better to come to speech therapy as early as possible. Early intervention leads to better outcomes. Speech therapy provides caregiver training as their essential part in Parkinson's care. Speech therapy play very important role within the interdisciplinary care team. Your treatment will be customized to fit your specific needs. Every patient is very different, so we plan according to the patient's needs. Thank you. I'll pass it on to him.
All right, we are nearing the end of our presentation. Thank you for sitting with us. We just wanted to touch base on just some resources out there for Parkinson's out in our community. Like our colleagues mentioned earlier, Parkinson's not only affects the patient, but family and caregivers. And we acknowledge that it is a very big life change, not only for the patient, but their loved ones and caregivers. Caregiver burnout is real, and it's a very common thing that most people experience. We want to make sure that you guys are also equipped, because if you're not taken care of, the patients aren't also taken care of. And so we encourage you, accept help as you need. Ask friends and family around you to support you in whatever ways that they can. There's also different tools for stress management, and this might be where support groups and things like that come into play, where you can engage with other families that are going through similar situations. And then finally, we just wanted to provide you with some information on different resources out there. There are so many different organizations and groups that support patients and caregivers regarding Parkinson's, and different tools out there. Some of them are out here today, and I encourage you guys to go chat with them and see what they're all about. Some of them are also local and specific to OT, PT, and speech, and on the slides you'll see them, and so please refer to them, look at them, and see what of those would be a benefit to you.
Okay, we finally made it. We have made it to our question and answer part of our presentation. One last thing I'm going to say before we start those questions is thank you. Thank you for sitting with us, listening, standing for part of it. If you don't want to ask your question today, feel free to snap a picture of emails. You can always email us questions as well. But thank you.
So, first, do you all have openings? I mean, you all sounded so amazing, and we really appreciate your outlining in depth some of the differences in these roles. I had a course of physical therapy and occupational therapy. It was 4 hours for 4 weeks. And you couldn't imagine covering all the stuff that you were talking about. So what periods of time do you usually see people over?
Okay, let's see if this thing works. That's a really great question. I think the way we typically like to set up our practice is not going to be the same as like the traditional LSVT big protocol. So just to jog your memory for everybody, that was the protocol that's like 4 times per week for 1 hour. Unfortunately, our clinics aren't set up easily like that. If that was something you wanted as like an exact protocol, that is something some of the therapists are certified in, and we'd have to set it up probably a month in advance. Most of my people who come in with Parkinson's, if they are somebody who is first diagnosed, probably see them once a week, maybe once every 2 weeks, for about a 40 to 45-minute session. We go through kind of the baseline, and then I send them off and I say, okay, as long as you feel good, I'm good, come in for a checkup every 6 months. If there's someone kind of in the middle stages of Parkinson's disease, then I ask them to come in a little bit more frequently. Maybe that's once a week, maybe that's once every, or 2 times a week, pending their availability. But usually that's the max that we can accommodate unless we do it out, like schedule it out a ways. But I'm gonna let anyone else answer that if they have a different question. Okay, does that answer your question? You asked if we had openings. Are you asking how long it would take to get into the clinic? Because that's a common question people struggle with too. I'll be honest, UT Southwestern is specific in how they book us. We usually are full about a month out. So after I see someone for the first time, I warn them. I'm like, it's gonna be probably 2 weeks before I get to see you again consistently. After that time, most of my people get in consistently.
My physical therapist and occupational therapist work together. And I was basically doing the same thing, the big program, you know, with the stepping forward and all those kind of things. But it didn't seem like there would be a lot of time for some of the other things that you were talking about.
That's a really great thought. You're right. I would say that's why research is leaning away from traditional LSVT big protocols. It's because it was so rigorous in doing these specific steps that you sometimes don't get to do as much of the functional training afterwards. I specifically got my power certification because I felt like it would be a easier way to give people those exercises to continue to practice, and we can use like our valuable time together as more functional training. So that's a great thought. Okay, go ahead, next question.
Yes. Now, this question might be for all four of you. Have you found that Parkinson's and strokes are sort of similar in some cases?
Yes. Yes, in some cases, but not always. Because coming to speech perspective, with stroke, they usually have the language impairment. With Parkinson's, they usually have the speech impairment. The speech intelligibility is like when you talk, the speech is not clear, but with the stroke, you have a language component involved over there, and they can make sentences, sometimes they can carry out the conversation. But with Parkinson's, what we see is like they have a lot of diaphragmatic weakness and the labial, like lip weakness and tongue weakness, but in stroke patient, we usually don't.
From an occupational therapy standpoint, I would say, strokes are so unique too. It just kind of depends on what part of the brains have been affected. And so you might have some people that have more cognitive changes or maybe more balance versus other people who might have like one side that's completely just weak or even paralyzed. Versus Parkinson's, you tend to see more, they may not have lost full movement, but maybe it's more of just that rigidity or like that slow motion, slow movement. But sometimes we can still kind of use some of the same concepts depending on, what their deficits are.
No, definitely going along with that, I agree with Jensen. We can use similar strategies between stroke and Parkinson's to help with our patients. I think of one particular patient that I had, his type of stroke that he had affected the basal ganglia, which is what's affected in Parkinson's. So he had Parkinson's-like symptoms, but he didn't have Parkinson's. And so sometimes things can overlap, but we use similar strategies to treat that patient in front of us. So again, it's specializing what we're seeing in that moment, kind of using our toolbox, so to speak, in that moment to help address those specific needs.
Appreciate the focus on multiplexing, teaching how to walk and talk at the same time. But I am concerned a little bit about, especially for newer people, there's some limits on being able to walk and talk at the same time. At what point do you introduce the issues with autonomic function, losing the autonomic function?
Are you asking for people who have different symptoms, like when we would start working on something like a dual task?
I'm concerned about, as people come in our gym, I tell them, rule number one is don't fall. And that means don't walk and talk across the gym at the same time. Because you'll trip and you'll get hurt, so.
So you bring up a really good point. There was an article I read recently and it talked about this idea of, for some patients, dual tasking, depending on where they are with Parkinson's, may not, you have to kind of change the strategy. For some people, you can do two things at once, right, depending on what stage they are. But the research showed that there becomes a particular point where you need to prioritize one thing at a time. And there are a couple patients that I have where we have that conversation of, okay, we've tried dual tasking and either the walking falls apart or our balance falls apart or we can't talk and have a conversation. So we pause, we do the task, maybe the walking piece, and then we resume a conversation after. So I would say this is my favorite thing to say as a therapist, it depends, but I would say it's patient specific. So if you've noticed that they can't do both, then say it's okay, I want you to keep what you have in your mind, pause for a second, complete the task, and then we can talk again. Yeah.
So as a speech language pathologist, we work on multitasking sometimes because the research has shown that if you stimulate the prefrontal cortex, it would help you multitasking. But I teach them only when the patients are really young. But when they're old, it's not advisable to multitask. I'm sorry.
I have a question for you. Have you ever used injections into the vocal cords for as a solution for a speech problem in Parkinson's?
There is a research, some of the research shows there's been improvement in vocal cord movements, but it's not proven completely though. Yeah.
Yes, I have a question. Have you had any experience with mobility service dogs or what your thoughts are that for Parkinson's?
I would say not specifically with Parkinson's. We do have some patients that come into our clinic for OT, speech, and PT that do have mobility dogs. I worked at a facility where we had a therapy dog that helped with different types of exercises. I do think it's beneficial. I would say this, knowing moving forward, right? We know that with speech, PT, OT, you're not going to be hanging out with us every day for the rest of your life, right? We want you to use some tips and tricks for maybe a couple months, and then we say, go do your thing, come back when you need us. If you find that that therapy dog is beneficial for you, or you really enjoy having it, and it's able to transform your life in a way that you didn't have before, go for it. I know they're tricky.
Thank you. How does stress impact muscle movement? And how do you assess what's a good exercise program and what's not doing you any good at all? Like I go to the gym and I do cardio and then I do weightlifting, but I'm not certain if it's elevating my heart rate enough to justify what you're talking about. So 2 questions.
That's a great question. Okay, I'm gonna start with your second one about how do you know if your exercise is effective? The complicated question or the complicated answer would be, I would want you to be doing activity that when you finish, you notice some changes in your symptoms post-exercise. I think general exercise, movement is beneficial always. If you are trying to figure out whether your cardio exercise is high enough intensity, that would be one thing. If you were my patient in the clinic, I'd actually stick a heart rate monitor on you. And I would show you the high enough intensity. Maybe we'd find ways to do that on like some kind of adaptive treadmill. We'd do it on a recumbent bike. And then I'd show you, okay, this is what it should feel like when you're practicing this at home. Let's see.
Can you repeat your first question? I'm so sorry.
The first question is just how does stress impact muscle movement?
So very good question. what I've noticed with the patients I've treated is when people are stressed, sometimes it can make those movements, I'd say more choppy, right? I think of a particular patient I'm seeing right now. When they get really stressed out, we have to pause because trying to focus and do things just does not work. And so we have to take a second. And I always like to tell people, reset, shake it off. It's okay, right? If you weren't successful the first time, we don't need to be successful the second time. Take a moment, pause. Because if your body is heightened, it's stressed, it's intense, it's gonna be harder to move, right? Because everything is getting tight, geared up, ready for something bad to happen theoretically. Our body can't tell the difference between good stress and bad stress. It just knows something's going on, tighten up, get tense, get ready. So if you notice that's happening, take a moment, use some of the strategies Jensen mentioned, some breathing, right? Use the diaphragmatic breathing Mahesh mentioned. Do something to kind of recognize in that moment, okay, I need to take a second, regroup, come back, and then try that movement again. If we try to do something when we're stressed out, it's not going to be beneficial. We have to take that conscious moment to kind of reset.
Yeah, going off of that, like we have the fight or flight response, right? So that stress impacts different parts of our brain. And so then we're not able to really use the movements that we can because we're so focused on that fight or flight, right? We're just trying to get out of that moment, so.
To play off of that question about how do we know things are intense enough, as we age, we may or may not have more cardiac impairments, and maybe we may be on a beta blocker that may blunt the response. How would you, for example, coach a patient in the clinic on, hey, instead of looking at our heart rate, these are the other things that we want to look at to make sure we're getting the right intensity?
Good question. The easy answer on that one is going to be what we call an RPE scale. For people that do come in with a blunted heart rate response, usually we try and ask those questions on the first day, or we'll notice it while we're working. We'll be like, heart rate's not getting up like we expect. We have little charts on all of our cardio equipment that say from 0 to 10 or 0 to 20, how hard do you feel like you're working right now? Because technically, high intensity movement on the 0 to 10 scale is going to be above 70 or above a 7 on that scale of like, how hard am I working? So I would probably teach people to use that scale instead of their heart rate directly.
Okay, I guess we've run out of time. We do have, okay, let's do one question.
One thing I would caution everybody to do is on every medical form and every application you fill out, when did you get diagnosed with Parkinson? And you just take the date that you saw the neurologist. You may have had Parkinson's, I know in my case, for years before that. So you have to self-search and go back and say, no, the symptoms began back in such and such a year. So be careful of the time sequence. Your physical therapist can judge the treatments based on the period that it's taken you to get to a certain point. Not to sound commercial, but if you go to Amazon, it's not my favorite place, and type in Parkinson's, you'll find a whole section of devices and utensils for Parkinson's patient. Buttonhole, cooking utensils, dining utensils, everything. So it's about, I don't know, 400 or 500 items. Amazon.com.
Okay, thank you so much for such an excellent session. Okay, lunch is served. We have options here for you. So we will come back for another excellent session. Okay, we are ready for our next final session. So I am just going to let Dr. McDaniels and Connie Cornwell introduce the session to you all, and we'll take it from there.
Welcome back from lunch. This is the best session of the day, right? Everybody gets full and sleepy, and they come back, and we're supposed to keep your attention for the next hour. So we will do our best, and we're excited about this session. You know, we've had 2 sessions previous to this in the Mind Matters series, talking about the emotional landscape of Parkinson's. And belonging and connection. And today we're going to go into a third session where it's really going to be a conversation, we hope. We've got care partners of people with Parkinson's on here and patients with Parkinson's, and just to hear a little bit about their experiences and an opportunity for you all to be able to ask them questions and hearing maybe things that they wish they knew years ago when this all began. And hopefully you can leave here with some answers, maybe some coping strategies, maybe some skills that you learn along the way that you didn't realize that were available to you. So that's all I had. Connie, let you go and then we'll get rolling.
Can you hear me? Am I on? I am on. No, I'm not on. Okay. Okay, can you hear me? No. I think that, wait a minute, let me see. Can you hear me now? Ah, there it is. Yeah, the magic mic. I'm Connie Cornwell, and I'm a licensed marriage and family therapist, an approved supervisor, a licensed counselor, and an approved supervisor. And my specialty is medical family therapy. And so today, I think our goal is to make sure that everyone's needs are met. That's not just patients, but that's all the caregivers as well. And Nuba had asked me to talk about what a family is. And to be honest with you, a family is whoever you define your family being, because a family changes over time due to loss or cutoffs and all kinds of things. So the traditional family of mom, dad, the kids, grandparents, and aunts and uncles really is not where we're at today, because things are evolving. So when you're talking about family, it's whoever you consider your family being. And I think probably what's happening when you're dealing with a chronic illness is that you expand that to include even the people who are providing the caregiving and also all the health providers as well. You may be actually seeing your health providers more often than you're seeing your own blood relations. So then that expands it to people saying, well, that's also part of my family. So just kind of wanted to open that up so that we're thinking broader than just our nuclear family. So I don't have much more to say. I think maybe the three people sitting between us should share who they are and what their advice is.
My name is Mary Ann Johnson, and I'm a care partner. My husband was diagnosed 15 years ago. He probably had symptoms 10 years before that. He's an avid golfer, and he had to start putting left-handed. That was a big change in his golf game. He's not with me today because he fell again on Easter and is waiting on back surgery. So my journey is long and complicated, and I will share whatever I can. And I'm going to start with, what do I wish someone had told me at the beginning? And that is that it really is a we disease. I live a lifestyle of Parkinson's, and I don't have Parkinson's. And I wish someone had stressed, and they may have, and I didn't listen. I could have had some denial at the beginning, but I wish they had stressed that it will progress. And I needed to figure out how to take care of myself long before that progression happened. And in the first 10 years, we saw no difference in life. And then all of a sudden, change happened, and now change is more rapid.
Hi, I'm Darlene Coffey. I'm a patient of UT Southwest. I was first diagnosed with essential tremor in 2018, but I had symptoms a long time prior to that I was a nurse for 30 years, but mainly pediatrics. So we don't deal with Parkinson's in pediatrics. So I didn't realize that the sleep apnea that I had, maybe the depression, the loss of sense of smell before COVID ever came. I thought that was a blessing in my line of work. And And then when I got the essential tremor, I was like, okay, essential tremor. And then I was diagnosed with Parkinson's in 22. So I've only been diagnosed a few years since then. What I wish someone had told me is that it doesn't have to define me. Parkinson's is not who I am, it's what I am. And I have to decide that every day when I wake up. I'm just gonna keep doing what I wanna do as long as I can do it. Thank you.
Hi, excuse me, I'm Dan Novak. I'm a person with Parkinson's. I've been diagnosed in 2008, so I'm going on 18 years. Things change over this journey. Things that were important to me back then are less important to me now, and things that are important now are maybe very different. So that's one of the things I'd like to encourage us to think about as we go through the next discussion. First, I would comment on Connie's role, comments on the role of the family. I would encourage us to think about the roles that we need in our lives, all those players that are important to our lives, and actually write them down, draw a diagram. I used to do this with my students as I was a consultant. Draw a picture of yourself in the middle, and then what are the roles around that are helping you? So whereas identity would be father, mother, daughter, son, but more importantly to us now is who's our support person when I'm down? Who's our support person when I need help in the yard? Who's my support person on the provider side? Who's my physical therapist and all that? We're all talking a lot more focus in the research now and on the role of the patient, and there ought to be patient-centered. Everything ought to be patient-centered. Well, I push back and say, okay, that's great talk, but so far I'm not seeing it. I don't feel patient-centered in my care team. It's hard to get that coordination. That's a challenge for all of us. And the UT Southwest is trying to do a good job of that. They're better than most, and I live in Fort Worth. I don't have patient-centered care yet. We have to make it up every step of the way. So I would encourage you to think of the people around you in that time frame and the role that they play, and make sure that you're intentional about the roles that you need. So we need people in our lives to help us with our spiritual and physical and so on. And so that's one way to think about it. So I'll stop there.
I just want to follow up on that, Dan. You mentioned the word roles, right? And I'm curious, how have each of you seen your roles change in the family system, right? Because it's a significant problem. You mentioned identity and roles. What's that looked like along the way?
Where Ray and I are today, I think the thing that I didn't expect was how much I have to advocate. And the first time I learned that lesson, we were traveling. And first time we used wheelchair assistance because we knew the distance would be long. And we changed planes in Heathrow. And not one bus, not two buses, but 3 buses refused to pick us up because Ray was in a wheelchair. We missed our flight. We waited 8 hours, and thank God for Viking. They made arrangements to pick us up at a different place on the river. But I didn't have an advocacy speech ready and articulate and not tied to tears. So advocacy is a bigger role for me now than it was. And there's, I mean, we could talk about forever the changes in a marriage, but it's still a marriage. It's still happy. I'm not going anywhere. We find different ways to experience joy together and as individuals.
That's great.
So for me, being a nurse for 30 years, I have 3 grown children, 6 grandchildren. My role changed almost immediately after my diagnosis. I had to give up my job because I have some cognitive issues. Could no longer remember how to get the med drips for the kids and didn't feel safe doing that job anymore. So I lost a part of my identity when I was diagnosed. There's a difference in power because my youngest son is who I live with. He's my caretaker. He's had to take on some roles that I don't think a child expects to take from their parent until they're older than I am. And so there's been we've had to balance our power a little bit. And I think sometimes, I don't always consider him as my caretaker when he says something, because I'm thinking, I potty trained you. How dare you raise your voice to me? But, I think we're both learning. And I think that it's gonna be many years of us learning to give up a little power on both sides and how to speak to each other so that we're kind to each other at the same time that we're taking care of each other.
I just want to highlight something you're saying, Darlene, that you have been a nurse, you've been in the role of caregiver your entire life.
Right.
And now that has shifted.
Right.
So now are you getting to have the experience of not being the giver, but now you're learning how to receive?
Right, I've been a caregiver for 30 years, and actually 40, because my daughter's 40. I've raised, my daughter's a nurse, my granddaughter's about to graduate to be a nurse, so I've raised caregivers. So yeah, it's difficult to not be in the caregiver role and for me to step out of that, because I still want to be that to my children and to others. And one way that my son has encouraged me was when Dr. Sharma recommended me to be on the advisory. My son said, do it. You need to do it. And he knew that would help me with part of that caregiver identity. So.
Yeah, so I spent 31 years at IBM, so I was an IBMer. And then I lost that role and I became a professor and a department chair. And so all of a sudden I was Dr. Novak professor. And my goal was to be able to coach and teach young leaders for the rest of my life. And obviously that role had to change. So that's a big shock on everybody's system. And I didn't handle it so well. But what has provided an opportunity for me is I've ended up volunteering in a lot of different assignments. So I've been on national patient advisory councils. I've been until yesterday, I was doing grant reviews for the National Institute of Health, NIH. They have a division called PCORI, Patient-Centered Outcomes Research Institute. So I've been playing the role of the patient for 6 or 8 years now with them, doing lots of grant reviews and feeling like I was not only helping shape the Parkinson's community, but the national health dialogue on the community. But I had to give that role up. As of yesterday, I officially turned down my last offer. They invited me to participate in this next round. I said, can't do it. Can't type, can't write, can't think, can't concentrate long enough. And they wanted more detail. They said, we're moving towards this next round to be even more detailed. So that's not me anymore. I'm having a hard time just keeping my thoughts straight in a sentence, much less doing a whole diagram. But what has given me the opportunity is things like this, to speak for 5 minutes and feel like I'm contributing something and teaching something and getting to participate in something. So it's hard to find those, but I'd encourage you to keep looking for those opportunities.
I think we just kind of wanted to get the ball rolling. And I know we've got some microphones going around. And if you've got questions for them, ask. It's a great opportunity to hear from people who have and are experiencing things that you may also be experiencing. I know we've got one over here. So yeah, I think that, let's see what we've got out here.
I would like to know what your caregiver speech was.
Well, the first one was pretty ugly. They were putting several men into wheelchairs, and there was a woman waiting at the entrance of the airplane, huffing and puffing, her arms crossed, and said, do you realize there are 200 people waiting to get off this plane? And I said, I didn't huff and puff, but I said, do you realize they are doing the best they can? and you don't know what you don't know, so just how about 2 minutes of patience? But I had to work on it from there, and it depends on what I'm advocating for. Sometimes it's learning to ask for help. That's a form of advocacy, right? I'm not good at it because I was a problem solver. It's what I did in my 35-year career. And there are 3 categories of advocacy for me, if you will. They're the things I do because I enjoy them and I want to do them. They're the things I outsource because I don't like to do them, or there's a need or talent I don't have. And then there's that category where I have to ask for help from friends and family. That's hard because of what Darlene said. I raise children, they're raising their own families, and they don't have the time, or I assume they don't have the time. In the medical space where I advocate, it's about being kind. It is about being direct and being articulate about what it is you're trying to accomplish from the beginning. And you have to keep it crisp. So if you need somebody to practice with, I'm there.
For me, as a patient, the most difficult part, being a retired nurse, is going into the doctor's office, and I'm used to speaking a certain way with physicians after 30 years. And I get treated differently. And most of them learn pretty quickly during my appointment that I'm not going to be spoken to in a certain way. And that's advocacy for myself. I still have the ability to understand what you say without you breaking it down into baby words. So I think we have to be our own advocates sometimes. And if you need that further explanation, you need them to stop and say, hey, yeah, I want you to stop right there and explain that, what you just said to me. And that comes from me being a nurse and standing in the room with the doctor when they're doing rounds. And me knowing the patient doesn't understand what the doctor just said. So remember that you need to have enough power in yourself to say, slow down, I need this step by step, or yeah, I understand that, let's move on. So.
What we're asking for as patients is a little bit of dignity and respect. And that's hard to always get that across well in a clinical setting. But I mean, you don't always, you could take 5 seconds and at least figure out who you're talking to, as she just said. I mean, I had the privilege of serving on the National Board for Parkinson's Foundation. So I was hearing the latest and greatest from the guys that really know, and I would walk into an office or a setting where people would say, oh, you know, just stop and be quiet. You've obviously been Googling stuff. Well, no, this is not from Google. This is actually from the people that Dr. Stanley Fond, who's originated most of the foundations, most of the organizations you hear about there in Parkinson's were started by a guy named Dr. Stanley Fond, so anyhow, and then I already forgot my other point. I'll think of it and say it.
You will?
I will forget it all the time.
I'm curious, have you found when you visit your doctors, it's good to have someone with you, a family member, or someone else that you have trust in to be with you at these appointments? Because my own experience of going to the doctors, I forget what they're telling me, or I don't want to hear what they're going to tell me, you know? And I'm just wondering, do you find that helpful?
Yes, thank you. That was my other point.
Okay, go ahead.
Which was for us
read your mind.
to be clear about what we're asking for in the doctor's office. Number one, I'm an old professor, right? Do your homework. Don't come in with a list of 48 questions that have already been answered a million times in the press and in the good stuff, which we'll talk about in a second. But so do your homework before you walk in. And then second thing is, what's important to you today? What do you value today? And figure those out, and pick your top 3. And don't worry about the rest of them. You don't have time to get the rest of them done, and you won't remember them anyhow. So just get the top 3 values today, and if you are able to walk into your clinician's office and the doctor says, I've only got 15 minutes today, I said, no problem, I've got it. Here's number 1, here's number 2, here's number 3. And that will help a lot. It's so frustrating. Patients are a pain in the rear. I mean, we're terrible at that stuff, walking in with a list of 42 questions, and the doctor just spent 8 hours answering that question for the people that were in front of you. So give them a break, do your homework.
Right. I take a notebook with me too, and usually it's my top 1 or 2 questions that I have at that moment. I realize that their time is very valuable and they don't get very much of it because of insurance and, everything. So I usually take my top 1 or 2 questions, and the rest I can, if I need to, I can send a note. They can message me back if it's that important.
I do go to all of Ray's appointments with him at this point, and I have a medical journal. Grab and go, where I keep notes, and if Dr. Hertzie asks, what's it looked like, or I have a place to go. I also keep a copy of that medical journal at the front door and in the car, so that it is wherever we might need it.
Any questions out there? We can keep going with this, or?
You asked about the caregiver. My son doesn't generally come with me to my appointments yet. I still drive. But he is very important in noticing things. And he asked me the other day, he said, "When's your next appointment?" And I told him, "Well, it's supposed to be coming up in June." I said, "Why?" And he said, "You're making a face." And I said, "All the time, or just when?" And he said, "You're kind of squinting like you hurt." And I didn't realize I was doing that until after he mentioned it. So they are very important to notice those subtle things that you don't notice yourself. And you have to give them the power to tell you what you're doing differently and what they're seeing. And I'm glad that he felt he had that power and could help me with that. So yeah, that'll be on my next topic.
So we've kind of heard some of the challenges of being a patient and a care partner, someone with Parkinson's. What have you all found in your lives to be effective coping strategies, right? To deal with the distress, the anxiety, the depression, right? Because the same things that we see with someone with Parkinson's, we see with the care partners. And what do? You found effective ways to manage all of it.
When I first retired, somebody asked me, "What's a perfect day for Mary Ann?" And I couldn't answer the question. So I spent some time reflecting, and there are 5 things on that list, and those perfect things have changed over time. I know I'm in trouble when one of 2 things happens. I'm an off-the-chart extrovert, so if I start to hibernate, something's not right. And the second thing is if I find I can't separate Parkinson's from Ray. Ray is not Parkinson's. Parkinson's doesn't define Ray. But if I'm having trouble separating those 2, then it's time for Mary Ann to get away. And so one of my coping strategies is I've learned, and it takes 3 or 4 months, about that repeat pattern. I have to go put my feet in nature, do something at my pace, not talk about Parkinson's, be with people I care about and who care about me. That doesn't fit for everyone, and I understand having people around who can care for Ray in my absence helps me be able to do that, but that is a coping strategy. A second coping strategy, which is more day-to-day, is I try and protect Tuesdays and Thursdays as Mary Ann days. So our doctor's appointments are Monday, Wednesday, Friday. Ray sings with Parkinson's Voice Project. By the way, it's a wonderful organization. Please make sure you spend time with them. That's on Wednesdays. So if I can protect some Mary Ann time, I do that. And the third coping strategy, which is both of us, is I schedule playtime. Playtime for him, playtime for me, and playtime together.
That's great.
So I'm just the opposite from Mary Ann. I've always been an introvert, and I prefer isolation. I prefer solid individual things. I like reading. I'd rather be in my room reading than be out in the public. But I've learned that I have to get out, because if I don't, it makes my depression worse. And my son has tricked me into, I say it's a trick, he bought season tickets to the musicals. So I know I have to get out once a month and go to that musical with him. But that was something that I realized after he did it, that he was getting me out of the house. Dr. Sharma has tricked me into exercise. So I leave the house at least 3 times a week and go walk at the YMCA and the pool, because I don't like any other exercise. But my son finally came down to, well, you like the pool, you could walk in the pool. And so he has helped me come up with different coping things that also get me out of the house to be more social, because he has realized that I need to be more social. Because before being a nurse, I had to be social. That was my 12 hours, 3 times a week, where I had to talk to people. Otherwise, I was in my room. And then he saw, well, she's not even doing her 3 times a week. So yeah, he's tricked me, but he's an extrovert, so.
So I don't have an answer to your question yet, Brad, because our situation just changed in my house. So my wife has never considered herself a traditional caregiver. She's busy, and she sees me as a person that doesn't need her help. And so that's been tough to get her to see me as, well, I shouldn't say that. I don't want to be seen as somebody that needs help, but it's happening. And it's happening a lot in the last year. As I talked about, things change over your time. They change a lot as you get toward as you progress further into the advanced disease. All of a sudden, you'll see a dramatic change in how the symptoms really hit you. So all of a sudden, I've been needing more of her help recently. And then 2 weeks ago, she had a stroke and was in the hospital for 5 days. So I was back playing caregiver. So I had to be her caregiver for a week. And that just about wore me out, trying to walk with my symptoms and all that stuff back and forth to the hospital. So now all of a sudden in our house, we're trying to adapt roles where both of us are in the ditch and need help and need care. And so that's a tough transition for us.
I want to go on the heels of that and ask you guys, in terms of caregiving, how are you sourcing other caregivers to support you as patients and caregivers? How are you going about doing that? Anyone?
Well, I have 3 children. And when I was first diagnosed, I sat down with my kids. And backstory is my dad also had essential tremor, then was Parkinson's, and ended up with Lewy body. So I witnessed his path. My children witnessed his path. So I sat down with them as soon as I was diagnosed, and they came up with a plan. With me, they decided that they felt like I should retire and I should spend the years that I have left enjoying the time that I have left. And they came up with the plan I would live with my youngest son, and whenever skilled help was needed, then the older 2 would help pay for that. So we have came up with that source right away. This is what we're going to do. And it was one of the first things we did, and I think it was from seeing my dad's path.
Well, I talked about I have this list of things I outsource. And it's not a long list, and it's my list. But asking for help beyond paying someone, because I don't have endless funds either, and I have 1 child, as 2 young children and a 3rd on the way. And my husband's girls, one also has children, and so I've had to teach myself to ask, and to ask broader than just family. There are friends who want to do what they can for either me or for Ray, and so I'm exploring using an app called Lotsa, which is where I can post things that I might need help with, and I can send it to that group of family and friends, and they can sign up. So they're self-selecting in, you know how if someone's sick or dies and they say to you, well, call me if you need something. That's just one more thing for me to worry about, is to decide what you can do to help. So now I can just say, okay, here are the 5 things I need help with in the next month. You choose if you have time to help.
I think some people, I've learned, are tied into churches and have found that to be a great source of people coming in and helping with the caregiving load, or they're tied into some organization or some group or club that they've been a part of. So they've drawn extra help from those places too. But if you're kind of a solo person and you're living out there dealing with this disease and you don't have any family nearby, it makes it tough. So I like that. Lots of, what's it called again?
Lots.
Okay.
Lots of helping hands.
Okay, did everybody get that one?
I think it's LOTZ.
LOTZ.
We'll get it out. Or it's on my phone over there.
There was something else it comes from hearing you talk about something recently, Mary Ann, and that had to do with friendships and how they kind of make assumptions about you and then end up maybe not including you as often. Could you talk something more about that? Because I think it's important.
So as a couple, our social life has certainly changed over time. And some of those friendships that I would say were more on the outskirts have kind of gone away because they don't quite know what to do with Ray. And those people who've been close and good, they meet Ray where he is. And so we find time to socialize as a couple. It's just changed a lot in how we do that. But Connie's talking about a recent experience where I had a girlfriend of mine and a good friend, somebody I've known for 33 years, say, well, I didn't invite you to X because you have so much on your plate. And I can't tell you how pissed off I was that somebody was making decisions for me as to what I could and couldn't do. And so I circled back and had the conversation with her that said, look, I appreciate how much you care for me, but please don't assume. I still want to decide what I can and cannot do, and I could have hired care for Ray if I chose to do that thing. So please still invite. If you don't want me to be there, that's a whole separate thing, but don't decide what I can and cannot do.
It's almost like, as we talked before, they were seeing you as having the disease as well as your husband, and they were just lumping you together, not realizing that it's not who you are, it's what you're experiencing. And that's a shame, because I'm wondering how often that happens for people.
And I was probably ultra sensitive because my biggest fear is that I will lose myself or have health impact, my health impact, because of the demands of Parkinson's. And I know Parkinson's has changed me, but I haven't lost myself, and I don't intend to.
I have to give one shout out to my big brother. He'll show, excuse me, I also have pseudobulbar effect. For those of you who know what that is, I can cry on anything. My big brother will pick up the phone and say, I'm gonna come, you want me to come this Saturday or next Saturday, and I'll spend the day. And we'll work all day. And he's the only, lots of people say, call me when you need me, call me for help, and all that stuff. And I missed a doctor's appointment a week ago because I couldn't drive, and all of a sudden my wife couldn't drive either. And my brother will show up and just work his tail off all day and go home. And that's how we get real help.
I'd like to know how many of you belong to a support group, and how often do you meet, and what are your meetings like?
Well, I participate in a bunch of support groups. No, I don't actually have a close single support group, but back to my conversation earlier on roles that are out there. And my contribution to the Parkinson's community was to provide as much information as I could. So I literally have participated in every group I could get my hands on. I listened to every webinar that I could for years and years. I've just now recently faded out on that, but that was important to me, to be able to provide a good source of information to the community community of those out there. But my support group is actually my boxing group. So I participate in Punching Out Parkinson's. They have since 2012, and so that's my group. But now all of a sudden I'm missing them because I need hip surgery and knee surgery and everything else, and I can't hardly get it done. And all of a sudden driving is an issue, logistics are an issue, and the challenge is, I mean, these are good guys, but nobody's, only one of them shows up, says, Dan, how you doing? So that's a challenge for all of us is to make those relationships real.
I don't belong to a support group yet. I'm looking for a good one. But I just moved to Dallas about 1.5 years ago. I lived in San Antonio prior to that. My children are my support group. I have good friends from being a nurse for so long that are support group. I have to say, like Connie, her friend made the decision for her. My kids are very encouraging. Mom, go do this, do it now. You can do anything you want to do. It was friends that said, I'm going to Alaska in a couple weeks on a cruise, and then I'm going up to Denali for a few days. And my friends were like, really, you think you can do that? And it was my kids instead that said, oh, you can do this, go do it. So I think choosing your support is also very wise because you need those people back there that are cheerleading for you, that are not trying to hold you back from playing mahjong or going to Alaska. Whatever you want to do, they're back there cheering for you and asking, how can we help you get that done?
The question. I am older than my husband, and he's the one that is diagnosed with Parkinson's. And I have two concerns. One is that I am actually afraid to get studies done on my own mental capacity because I'm afraid I cannot afford to have a problem. But the other thing is that when I look at my children, I realize, and this has been very helpful, that although, we have discussed things like medical powers of attorney and things, my kids are not educated in Parkinson's. I mean, they know the word of the diagnosis, but as I did. But even as a retired physician, I knew nothing about Parkinson's. Well, I'm a neonatologist, so I don't see Parkinson's. But I have been coming to these seminars and reading some of the materials that come to the house, and I'm much more educated, but it didn't occur to me till today that we have got to educate our kids. Now, they have their own problems and they're trying to build their own families, and one of them is fairly nearby, but the other one is on the East Coast. But I think although they know the word, they don't know what's ahead. And when it comes to making decisions, when I heard about your family experience, we have had none of that as any kind of preparation for them. And I'm realizing that it's past time to do that. So this has been very useful.
Yeah,
Thank
and
you.
I want to highlight, it's so important that you educate your family members what's going on, because actually you're helping to empower them so then they can be better at supporting you, because children are busy, they have their own lives, but it's not that they don't want to be participating with you and supporting you. It's just that they don't always know the questions to ask, or they don't know, what should I be doing? So the more you can empower your children with information and education, but also letting them know, hey, as things progress, we're going to have to talk about having extra help, or we're going to need to talk about how we're going to continue living. I mean, children will appreciate that because they won't know otherwise. So I'm glad you're highlighting that.
Because I think if you were to send your kids to some of the various websites that we all use to understand what could be for the person with Parkinson's, there's a really long list of symptoms that they could experience. And that could be overwhelming all at once, that my mom or my dad is going to have this list of 25 things. Maybe 18 months ago, I send a note to our children once a quarter, maybe once every 6 months, that says, you know, this is what we've seen in change. This stays consistent. And not too much information, because some of the symptoms are not something you really want to talk about. But enough for them to know that if dad is more fatigued, that's a symptom of Parkinson's, and here's how it's going to play out, especially with our grandchildren around. We have one who's a wild child, and Ray can take about 1 hour. And it's why we don't have her spend the night, because it takes him down so hard. So that's not personal against Allie. Love and adore her, and she's her own special snowflake, but it's the impact to Ray, protecting his safety.
There's so much information that's available out there now. A little plug for Parkinson's Foundation. They have a 1-800 number you can call and ask any question. So your kid's example can call them up, say, I've got a symptom I don't know what to do with. Second is they've also, all of the foundations have been doing a better job on organizing the material that's on their websites. So you can now go into Parkinson.org and do an AI search. And now they just introduced a new AI feature called Pam. And I haven't used her yet, but anyhow, I go in, I do a search, I get every fact sheet, every symptom on Parkinson's. You get a fact sheet on there that's been reviewed by, written by credentialed people. So that's a good source to you. But back to your original point, we just signed all our paperwork yesterday for our elder care, all our documents, we updated them all. I would consider strongly, as I went to school a lot, the more I learned, the more I realized I didn't know. I would encourage you to think about experts on your caregiver as a guardian for your husband's decisions. I would try to get an expert, somebody who's knowledgeable, to be a joint participant on there. For example, you could have your kid and as a co-executor or a co-guardian on the will, and invite get somebody who will volunteer to serve with you, who actually knows, because as she just said, there's so much information out there that there's so much that neurologists are required to know to adequately diagnose every symptom. It's impossible for them to keep up with it. So, and there's only 6 or 8 movement disorder specialists in Dallas-Fort Worth. So they would be more current on everything that's out there, but even then, they're a limited audience there. But I would try to get somebody who knows what they're doing. I would not pretend that my kids could know. Matter of fact, I specifically took my son and daughter off of my list, so they are not eligible to be my guardian, because I don't trust the decision that they might make.
Well, I think it's a power thing too, on giving your children that power to say, you have a say in how this is going to happen too, because they may be affected, so it's that give and take of power again. And one of the first things that we did was set up my trust and my power of attorney. And that I think that comes from working in healthcare so long, that I knew I needed those in place, because I wanted to say, I don't want this, this, or this. And I didn't want there to be any fight between the 3 of them. And I knew there would be, because that's what kids do, is fight with each other. But it's very important that you enable them to say, you tell me what you think should happen, and I'll tell you what I want to happen.
I have a question, but specifically it's not about just Parkinson, just in general for people that they have conditions that other people can see. Like mine, I had to do surgery, so that's why right now I'm walking with the walker. Back into the job thing that you mentioned, the nurse lady you mentioned, sorry, I forgot your name. And you said you had to retire because of your diagnosis. So for other people that are young like me, and it's not the time for us to retire. Right now, for example, I'm facing problem and issues in getting to the job, basically market. Because as I can see, I'm talking about my personal experience, there is going to be a lot of discrimination. And even when you apply for the job and there is a question, it says if you have disability or you don't, or I don't want to say. So if I do put I have, I'm going to be out from the application process. And if I don't put I don't want to say, then they would say, okay, that might be a catch there, so why not? And then although I know that I can do whatever it needs for that job, according to the job description, and I'm qualified for it, so I just put, no, I don't have. The problem is when I go to the interview, then again, I'm gonna be judged by the cover. And then I'm not gonna be offered with the job position. So what is gonna be your coping strategy, or I don't know, how do you call it, for you that right now you have seen yourself change because this is not you, or like this is not me, it's just I have this, but it's not me, it's not gonna define me. So what would be in real life for you, like how do you feel right now? And if you wanna go back to job market and start working again, not just as a nurse, other opportunities, how would you express yourself and present yourself? To be honest, I have been facing this for a long time, and every time I go, the door would be slammed on me. I don't have Parkinson, but I had surgery. So if there is any sources or anything that I may not be aware of, I would appreciate if anyone knows that. I even talked to EEO department, they didn't help. I talked to DARS, they said you're overqualified. So if there is anything that can be helpful, I appreciate everyone to share with us.
Well, for me, I was close enough. I just turned 60. So I applied for disability because nurses aren't rich. And I applied for disability. It took me 1.5 years to get my disability, but I was approved the first time. But you have to have all of your documentation in place to do that. I would say to you, I would talk to ADA because they are not supposed to judge you on your disability. And that's an ADA issue. So.
I'm a retired HR executive, so we may want to have a conversation afterwards because it's big and it's complex. But to what Darlene said, it's illegal, right, to discriminate based on any sort of factor, whether it's religion or color or disability, a whole host of things. Physical too. Okay. Mm-hmm.
The things that I need to do. So that's why I'm really challenging. And one of the reasons why I came today was just getting to know people and maybe sharing something that they might know something else on other sources that I'm not aware of.
All right, we'll talk offline.
Yeah, because they can't legally discriminate in that way. I mean, there's laws. Lots of them.
Just on the other side of that, you're right, there are laws, and the ADA is clear. The challenge becomes, as an HR person or a hiring person, you just can't say, I'm not hiring you because of your disability. They can still choose to say, you weren't the best fit for the job. And that's the challenge with, the law in theory is wonderful. In practice, the ADA has some holes. So it's a precarious position for sure.
Because if you're not right, they'll say you're overqualified.
Right.
Yeah.
The other thing that you might,
I think we have some other questions.
the other option is vocational rehabilitation. Those offices offer some pretty good services.
I want to just talk about the simple issue of driving. What made you decide to do that? I want to talk about driving. What made you decide that you could no longer drive?
When I really soaked in on the fact that it's not me that I'm worried about, it's the people I run into. I mean, that's the short answer. Also in Parkinson's, there's a tendency towards behaviors that are not appropriate, such as driving yourself into a brick wall, things like that. So I would find myself doing 90 miles an hour on the way to the doctor's appointment in Dallas and enjoying it. So anyhow, so I knew I was risky, making risky choices, and physically I can still drive. I mean, a few months ago I drove 2 guys over to Dallas with me to the DAPS seminar, but still, it's just when it really soaks in. Tiger Woods, some of these guys, you think about the fact that somebody else is going to get killed out here. That's why I quit driving. But I still take to the grocery store. It's only a couple blocks away, and I stay off the main roads. So
I still drive, but that tricky son of mine tricks me about once a month into driving him. He'll say, "Oh, I don't feel like driving. You drive today, Mom." And I know he's testing me, but he was the kid that wrote the email to his principal too and signed my name to it. So I know he's a tricky kid.
For Ray is gait driven, and so that freeze on gait started to play in his ability to walk, which we translated to that could happen in your ability to hit a brake. My husband's a retired physician, and so hurting someone else was, and preventing that was important to both of us. And maybe 6 months ago, I was driving, we're headed to a doctor's appointment, and somebody pulled very fast on my right side, and Ray froze so badly in the front seat when he kind of came back to unfrozen. He looked at me and said, "Thank God I stopped driving 18 months ago, because I'm not sure I would have handled that in any safe way." So, but we talked about it for 2 years before he and I made the decision. And the way we started is I did all of our night driving for about 2 years before he stopped driving.
Now, I know from my dad's pathway, taking his keys was one of the hardest things we did as children. And he was a professional truck driver. So he had a lot of experience driving, but it was when we first figured out he had Lewy body, and he was driving himself from New Mexico to Indiana, and he was found in somebody's doghouse in their backyard because he had that whole hallucination thing. And that's when we had to take his keys. I wish somebody had tricked him like my son tricks me once a month, and we didn't have that scenario. But yeah, that's how he lost his.
yeah, it's really about processing speed and being able to handle multiple inputs. Back to my comments earlier today about multiplexing. It's an ultimate demand in multiplexing. For you to be able to drive and absorb all those inputs coming to you at one time, and your processing speed is going to be slow. So that's the point. That's why I also say I'm comfortable driving a couple blocks to the grocery store, because I'm able to limit the number of inputs I have coming to me, and I don't have the radio on or anything else.
I want to be mindful of time. Oh, we still have another question.
And then she's gone.
One back there, Janice.
I just want to thank you all for coming and speaking today. We do home health, and I'm not trying to pitch a line, but I get to see it all full circle. I get to see the family, I get to engage with them, I get to educate them, I get to spend time with them, I get the kids on the phone, and I just am so grateful because a lot of things that you said hit home for me today, and I'm gonna take it with, we all have at least 20 years of experience in home health here. So thank you, thank you, thank you.
Well, thank you.
Janice.
Hi there, my name is Shelby. I'm an ATF medical assistant with the neurology department. So Potentially, some of y'all have gotten messages from me in regards to your medications, forms, etc. And I just wanted to touch base while I have the collective's ear about that. So first about like transitioning into disability or something, right? Say you're getting this diagnosis while you are still working. Our doctors are fantastic about allowing us to write you letters of support for your disability applications. So please, ask your doctors for those. We can get those drafted up for you and get those going your way. FMLA paperwork, if you have younger family members who are helping care for you, taking you to doctor's appointments, right? They can fill out FMLA to bring you so that they get time off and won't have their job affected or anything like that. So we want to support you like through that process as best we can. Ask your care team what we can do to help make that process easier for you and your family. And then my second point that I just wanted to touch on was the thing that we hate talking about, insurance, right? A lot of y'all are transitioning into Medicare if you're not already on it. And I would just please ask you to do your research on your Medicare Part D plans for your prescriptions, because we understand that your prescriptions a lot of the time are your lifelines to your daily life, that you can function in normal ways and things like that. And the less that we have to fight with your insurance company to get you approval, we don't want you to waste your money spending all of this money on an insurance plan that's not gonna cover your meds, right? So if you can look into that ahead of time to see what medications are on your formularies, etc., that is gonna help you guys in the long run, save money, and also help your care team provide the best care to you as fast as possible and maintain the stability of your care. So we would appreciate that and want the best for you.
So Anuba, have we reached our time, or do we have time for another question? Or
Sure.
I appreciate what you all are doing here. It really makes a difference. But I do want to plug the boxing group that's in South Lake, because we do have a support group that meets on the first Tuesday of the month while the Parkinson patients are actually doing their exercises in the boxing. So it works pretty well, and I've been participating in it for a few years.
is there another question, or? Okay. Was there a question? Okay, so you have a question. I'm gonna let you ask the question.
Yeah, because we have so many of our care team folks here, PTs, OTs, they're here for their continuing education credits. And I was wondering if you had something to share with them about what you would want for them to do better or do different. I'm sure they'd love to hear about that as well.
My request of my providers is to understand what I value today and what my values are, and my values change. So, trimmer, things like that, super important when we were first diagnosed and hardly on the scale now. So what's changed to me is, like I said, years ago I was trying to get my doctor to give me lots of medication so I could keep consulting and performing my job and being on the move and being active and all that. Now my top priority is to be able to spend time with my wife and to calm down, and I don't have a rush agenda anymore. And I need my doctors and had to adapt to that. And fortunately, I've got a doctor in Fort Worth now who understands that.
Well, I have had PT and speech therapy at home. PT balance is important for me, and learning how to do those balance exercises. I did have a fall last fall, and so I've learned some new strategies with that, and that came from having PT at home. I have some trouble swallowing, and I learned some strategies from the speech therapist on helping with that. So I think they're doing a great job. And luckily, I was able to get it at home because driving across Dallas 4 times a week is terrifying to me. I mentioned at the beginning that I wish someone had told me that Parkinson's was really a we disease. And so what I would want different and consistently from our providers in Ray's care team is to understand that I do live a Parkinson's lifestyle without having Parkinson's, and you may not actually know what it's like to be in my shoes. And so I want you to listen and to appreciate that more and more information about how to better care for my husband it's only a piece of my entire health that allows me to have a full cup and care for him. It's just a piece.
Well, I think, do you have any other comments, Bradley, or?
I don't. I thank you guys for being here, for sharing your thoughts and your experiences. I think there were some valuable things that you guys offered, and
Well, it's
we
like we
appreciate it.
talked before, these folks and the participants here are really the experts.
Yeah, that's
They
right.
really have the wisdom and the knowledge, and we just want to keep sharing that. One idea we had was, and those particularly who maybe don't like to speak in public, if you can jot down maybe 2 or 3 points of wisdoms, what you've learned or what you would like other people to know or what you would like to pass on to other people struggling with this illness. If you have some thoughts about it, please write them down on a piece of paper and we'll try to collect them somehow or I don't know.
Leave them on your feedback
Oh,
forms. You
yeah.
can email us too. But
Yeah.
if you can write those down on feedback forms, we collate them and keep them.
Yeah, because we want to pull from your wisdom because you're really the experts and it's always a privilege to be doing this and it's been fun doing this with all of you. I mean, I really think that these 3 people between us really are what it's about.
For sure.
Thank you.
Just very quickly, thank you to the panel, but I really want to thank Dr. McDaniels. The webinars have been fantastic. So these last 2, the part 1 and part 2, really got a lot out of it. So just wanted to plug that. It's amazing.
Thank you. And I'll plug Janice and Anuba for putting this whole thing together, right? They've been not only today, but the webinars leading up to today and the organization that takes to plan something like this and have it come off as well as it did today. So bravo to your work.
Thank you. Thank you for coming. Thank you very much. Do leave us feedback because that helps. Okay, so just for our continuing education credit folks, I am going to
like to speak in public to
have this out here for the therapy sign out. So speech, PT, and OT is here. And then for our nursing professionals, if you'll come down here at the table, I'll give you the information to sign out.